Good evening and very warm welcome to all respected dignitaries, esteemed faculties and dear colleagues. With folded hands, we welcome you all to the second module of Grand Anemia Conclave. We feel proud to share that this conclave was inaugurated by our Honorable Deputy CM Shri Keshav Prasad Maurya ji, who was kind enough to grace the occasion and which was attended and appreciated pan-India by more than 1,200 delegates. We are deeply indebted to our dynamic FOGSI President, Dr. Alpesh Gandhiji, and to all the FOGSI office bearers who have always blessed us in all our endeavors. In the last sessions, we have received the words of wisdom from all the stalwarts and discussed the burden of anemia and the diagnostic challenges involved. In our first module, there was discussion about the proper evaluation of complete blood count values, importance of thalassemia screening with increase in the migratory population, and shifting our focus on the diagnosis to premarital age group. Taking our motto of test, treat, and talk forwards, we are now heading towards the second step, that is the treatment of anemia. It is my proud privilege to invite our vibrant and most beloved senior, Dr. Preeti Kumar, Chairperson Safe Motherhood Committee, Organizing Secretary of AICOG 2020, a conference which is most remembered both today and forever. She is also Vice President Logs and has number of laurels to her credit, many publications and many numerous activities in various committees which she has served or chaired till date. I welcome you, ma'am.
Thank you, Bhavna. So on behalf of Safe Motherhood Committee, I would like to welcome all of you, especially the faculties and all the participants on this forum. It is indeed a proud moment for the Safe Motherhood Committee to organize this event, that is Virtual National Grand Anemia Conclave. And we thought of doing it in two parts. On the first day, we talked about the diagnosis, as Bhavna just now mentioned. And today we will discuss about the management part. The mission of doing this program was because 26th November is celebrated as Iron Deficiency Day. So we thought of keeping these two mega events on 27th and 30th of November. But I just want to say right now at this platform that this mission will not stop. The Safe Motherhood Committee has already conducted a survey with our OBGYNs, the FOGSI members, and a lot of postgraduate students have also participated in that program, in that survey, and we have come out with a very good data that still we need to work a lot for our members, and there are a lot of gaps as far as the practices and the management of anemia is concerned. So we will definitely in the next year, with the help of our president, and the support and guidance of our president, Dr. Alpesh ji, and in the second half by with the help of Dr. Shanta madam, we will definitely try to keep this on and on till we achieve the zero anemia in our country. So the mission is to make every mother safe while she's delivering, and even to all the adolescent girls who are there and who are anemic. So we want to work do a holistic approach in the management of anemia. So today we have a galaxy of experts. Thank you everyone for being here. And I would like to express my gratitude to our President, Dr. Alpesh Gandhiji, and the entire FOGSI fraternity, especially my Vice President, Dr. Atul Ganatra sir, and Dr. Jaideep Tank, who are always very, very kind and helpful. Whatever project I wish to go ahead, they are always eager to support and they motivate me a lot. Thank you so much, sir. I think Dr. Alpesh sir will not be able to join because he is busy with some.
Ma'am, he has joined. He has just not joined.
Sir has joined. Okay, thank you so much, sir. Thank you so much, sir, for joining today. And then before I stop my message, I would like to convey my thanks to my teacher, Dr. Chandravati ma'am and Dr. Meera Agnihotri ma'am, who are always by my side, guiding me, helping me for all my endeavors. So welcome you all once again, all the esteemed faculties and all the participants who have logged in today. So thank you so much, Bhavna. Now you can proceed with the session.
Thank you, ma'am, for your words of prudence. Beginning every event with the blessings of Lord Ganesha is our cultural heritage. I would now request FOGSI President Dr. Alpesh Gandhiji, Professor Chandravati Ma'am and Professor Meera Agnihotri Ma'am, all dignitaries and participants to join hands for the virtual Deep Prajwalan ceremony. Let's begin this auspicious ceremony with the quote, Vakratun Mahakay Surya Koti Samprabha Nirvighna Kurme Dev Sarv Karyeshu Sarvada.
वक्रतुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा.
We all are privileged to have the opportunity to work under guidance of Professor Chandravati Ma'am. And she is the National Advisor for Safe Motherhood Committee and is a motherly figure for almost all of us. With her innumerable achievements, she is a living legend. We welcome you, ma'am, and request you to shower your blessings on us and share your experiences about the management of anemia over the past few decades.
Thank you, Bhavna, and thank you, Preeti, and everyone, all the Committee of Safe Motherhood, for reviving me all the time and making me remember all the areas of safe motherhood burdens, what we need to do and what we still have to go ahead with law. Anemia had been a problem since I even was a student, became staff and became head and so on. We all from the beginning are trying to see that we don't get anemic women into the hospital. Sometimes even I went up to the past that tried to find out why anemic patients are still coming to the referral units as in the Queen Mary's Hospital of my department, in spite of all the government programs. But we never succeeded and the problem kept on going, though government was having programs after program. I was very happy to be present in the first Grand Anemia Conclave when there was diagnosis was being discussed and diagnostic modes were discussed and to find out the correct type of anemia. And once you know the correct type of anemia, that is the only answer when you can treat anemia. I was very happy to see a large number of people who had joined and the grant faculty who had taken part and really done the job wonderfully well. I'm happy today that we are going to discuss about the management part because it is what is needed. That how can we take this management part to the grassroots levels? What should we do that we can treat the anemia at the grassroots level? And as discussed earlier also in the first conclave, that we should see that our women do not enter pregnancy with a negative hemoglobin count. So that should be our first priority, that adolescents are not anemic. And if the adolescents are not anemic, about half of the job would be done when they become pregnant. And once the education is there, I think the 75% job would be done because we explained them. We would be left with the grassroots patients who have difficulty in going to the medical checkups, but we do have ASHA workers who are being trained and who are supplying iron folic acid to all these pregnant women. But still, I do not know. We need to find out why the compliance is so poor and why still so many women are coming with severe anemia into the second or third trimester, or sometimes even into labor with high degree of morbidity, mortality, and high degree of neonatal death. So we need to find out the type of anemia, and then only we can discuss about the correct treatment. And still, in spite of so many years, we are still on the lookout for a type of iron which would suit everyone. Because many times the compliance is poor because the iron does not suit the lady and she stops eating it. So they are there to find out new molecules The research is going on. Every day new molecule is coming. We gynecologists are testing it and trying to find out molecule which will suit majority of our women. And once it suits, I'm sure the compliance would be good. And if we eradicate the other causes of anemia with a good iron supplement, I think we would be done the job. So again, wish you all the success into this wonderful Anemia Conclave webinar today, our digital conclave. The faculty is so extremely good, and I'm sure the people who have logged in, all the delegates are going to be benefited with this. Wish you all a very, very grand success for this webinar. And Preeti, I'm sure you are going to eradicate anemia from India. Thank you very much, each one of you. Thank you.
Thank you so much, ma'am. Your blessings are so precious for us. Thank you for enlightening us. The greatest achievement is to outperform yourself. This holds true for our zestful FOGSI president, Dr. Alpesh Gandhi, who is always an outperformer. He is a pioneer in the HDU and critical care obstetrics, and his work in Community Connect program is creditable. His selfless services related to COVID are commendable. We welcome you, sir, and request you to enlighten us with your pearls of wisdom. Welcome, sir.
Thank you, Dr. Bhavna, for the kind words. Namaste, Chandravati madam. Namaste, Meera ji. Namaste, Manju madam. Dr. Uma ji, Dr. Krishnendu, Dr. Milind, Dr. Susila ji, Dr. Anita ji, Dr. Lakshmi, Dr. Aparna ji, all the esteemed faculties, and a very active, dynamic Safe Motherhood Committee Chairperson, Dr. Preeti Kumar, and the team of Safe Motherhood Committee, esteemed faculties and dear friends. A very good evening to all of you, and I extend warm welcome on behalf of FOGSI, on behalf of Safe Motherhood Committee, to all of you in this Grand Anemia Conclave 2020. As you all know, the primary mission of FOGSI is to reduce maternal mortality, neonatal mortality, and long-term and short-term morbidity. And we all know that anemia is directly or indirectly responsible for 20 to 40% of morbidity, mortality, and admission in obstetric HDU and ICU. The theme for this year, FOGSI, is Safety First, Safety for Indian Women and FOGSians. And I think without diagnosing, without treating, without eradicating anemia, it is very difficult to bring safety to our women. Dr. Jayam Kannan is doing a lot of work in South for the safety, for the antenatal care, for adoption of PHC centers. I know how much you all are active to eradicate anemia from our country. Just recently, FOGSI has conducted a 90 days campaign to eradicate anemia, to make India free of anemia. And our target is no adolescent girl should reach to 15 years of age without 12 grams of hemoglobin, and no pregnant women no women should become pregnant without hemoglobin minimum 11 gram%. And it was our target to reach maximum possible women, girls and women of India, and we have tried to reach, and we could successfully reach to 5 crore girls and women of India in this 90 days campaign. But once campaign is over, just recently over, it does not mean we have achieved our goals. And for that, we should continue such type of activities. And I am happy to see that Safe Motherhood Committee has taken up this, and Dr. Priti Kumar is working actively, very hard for this noble cause. And I think we all should continue this till we achieved our target. And I think by 2025, if we all decide today, it is a doable target. We can achieve this. It is not when in USA, only 6% women, girls and women are anemic, then why in India it should be 50 or 52 or 54%. So awareness is very, very important, and our efforts are also very important. I think today we all have decided this year to eradicate anemia, and I think in next 5 years, if we continue this activity, definitely by 2025 we would be able to eradicate anemia from our country, at least from girls and women of India. Today we have very interesting topics: management of iron deficiency anemia, management of megaloblastic anemia, management of postpartum anemia, anemia in pregnancy, paving the trodden path. And then we have a very interesting panel discussion. So many galaxy of experts across India are there. And I'm sure it will going to be a very, very interesting, very useful webinar. I wish grand success to this webinar. I wish happy learning to all of you. I wish safety to all of you. And once again, I congratulate Dr. Priti Kumar and Safe Motherhood Committee for this excellent program. Thank you.
Thank you so much, sir, for being so supportive always. Thank you so much, sir.
Thanks, sir, for your precious words and for enlightening us. We'll keep on doing good work under your able guidance.
Thank you.
Stepping forward in our campaign, that is March Against Anemia, I will now begin our first session on challenges in management of anemia. For this session, we invite and welcome our respected chairpersons, Dr. Jayam Kannan. She is an emeritus professor, MGR Medical University, Tamil Nadu. Recently, she has been honored by the honorary FRCOG. She has been Vice President FOGSI 2018, Chairperson Adolescent Health Committee, and received Best Committee Award during her tenure. Many publications and allocates are there to her credit. I also welcome Dr. Manju Shukla, ma'am. She is our dearest, ever charming, smiling, ever youthful, and most supportive mentor and guide for Safe Motherhood Committee. She has been past president UPCOG APGL Logs, and she is retired professor OBGYN KGMU, national trainer for contraceptive technology, EMOC, and quality assurance. We welcome Dr. Lakshmi Srikhande. She is a great academician, chairperson designate ICOG 2020, past vice president FOGSI, medical director Srikhande Fertility Clinic, Nagpur. She is national corresponding editor for Jogi and founder, patron, and president ISOPA Vidarbh chapter. I feel proud to invite our guest of honor, an eminent FOGSian and renowned teacher, Dr. Meera Agnihotri, ma'am, Professor and Head Department Obs and Gynae, GSVM Medical College, Kanpur. She is President of WWW Foundation, and she has organized International WWW.con, first ever any conference inaugurated by the President of India and Union Health Minister. She is advisor to Women Health Cell, Ministry of Health, Government of India, and President, Chairman, Ethics and Research Committee. Now I request Dr. Jayam Kannan, ma'am, to invite our first speaker, that is Dr. Sushila Rani, ma'am.
It is extremely a great honor for me to be a part of this grandeur. Anemia is such a subject which makes everybody look pale, but it is only Preeti and Alpesh who can make it grand with a red color and make this red the sharpest color. And Sushila Rani from South is a person who can deliver this topic to the best of the required needs with apt words, with apt feelings in the apt area. And she is the director of the Manjushri Hospital, consultant in Vikram and Bhagava Mahavir Jain Hospital. She is a chairperson of Postgraduate Forum Bangalore Society. She was a president Bangalore Society about a decade ago. She is a chapter secretary about 5 years ago. And a couple of years ago, she was a scientific chairperson of the SciDip. And last year, she had the big honor of being the scientific chairperson of ASVG 2019. And presently, she is a national advisor for this year to come conference. And over to you, Dr. Sushila Rani, to give your exuberant ideas on making quickly the management of iron deficiency in the Indian context.
Thank you, madam, for such a wonderful introduction to me. I don't think I deserve it. Many thanks to Dr. Alpesh Kanti, President of FOGSI, Dr. Preeti Kumar, the Chairperson Safe Motherhood Committee, and all the dignitaries and luminaries who are there on this web-based platform. I'll just start my screen. One second. Yes, got it. Is my screen visible?
Not yet, Sushila.
Okay, one second.
Can you please accept my request?
Yeah.
Yes, ma'am. Just now open your PPT. Your screen is visible.
Okay. Is it visible now?
Yes, yeah, there you are. There you are.
I'm sorry, I lost a couple.
It's okay. It always happens because we are in the cyclone zone, you know.
Yeah.
Waves are not good. I know very well. We have sent a newer to your place.
Yeah. 20-year-old primey, hemoglobin at 14 weeks, 10 grams, repeat HB at term 9.2 grams. She has an LSES, delayed wound healing, long convalescence, alive but unwell. What about the next pregnancy? So this is one preventable morbidity. 32-year-old, gravida 4, para 2, living to abortion 1, hemoglobin 9.1 grams at 28 weeks. She's treated with usual iron and calcium. Vaginal delivery, PPH, no blood available, maternal death, preventable mortality. 26-year-old, gravida 2, para 1, living 0, previous LSES for placenta previa, referred at 36 weeks. Hemoglobin was only 6 grams. She was given blood transfusion, repeat LSES, 6 units were transfused, saved, but at what cost? Morbidity and drain on resources. So here we are going to discuss the management of iron deficiency, anemia, and pregnancy, trying to save all these mothers. Now this comes in 2 parts. One is the correction of anemia itself, and 2, the obstetric management. Let us look at the correction of anemia. In India, iron deficiency is such a major cause for anemia that we can as well say anemia means iron deficiency anemia. Hence, replenishing iron is very important. We know we are very fond of silver. We know silver shines. We know gold glitters. But my dear friends, it is the iron which strengthens, and therefore iron is a major element in a woman's life. Initiating therapy in iron deficiency anemia aims at correcting iron deficiency. It also helps to restore iron reserve and to correct associated complicating factors. The choice of therapy depends upon the severity of anemia, the duration of pregnancy, and the associated complicating factors. So the treatment aspect of iron deficiency anemia comes in three forms. The most important one is the diet, and next comes the drugs, and the third is the blood. That means red blood cell transfusions. Now let us look at diet aspect of the correction. Dietary modifications are cheap and they are culturally acceptable. It's easy to bring about changes in the diet and correct the anemia. Iron absorption from a rice-based Indian diet in pregnancy is 13.3%, whereas wheat-based is 5.3% respectively. Certain drugs and dietary products prevent the absorption of oral iron. Dietary products including calcium in dairy products, cheese and oral supplements, calcium, tea and coffee, chocolate, spinach and beetroot, soy products come in the way of absorption of iron. Drugs like sulfonamides, calcium supplements that we give during pregnancy, antacids and anticonvulsants, all these come in the way of iron absorption. And at all times, apart from taking the right diet, the lucky iron fish is very important. What am I talking about? All you have to do is cook with it. It's an iron in the form of it's a fish in the form of iron. And all we need to do is put the fish in boiling water, remove after 10 minutes, add ingredients to the pot and enjoy an iron-rich meal. Put fish in every pot. This is something that we have picked up from other countries, and it's something which is very simple, something which we have been doing all along, cooking in iron pots and iron vessels, something which we had forgotten and we need to bring back. Vegetarian, of course, can put an iron potato instead of an iron fish. Deworming is a major aspect of managing anemia. WHO in 2017 said that where hookworm prevalence is more than 20%, the prevalence of anemia is more than 40%. Routine deworming after first trimester with either tab albendazole 400 milligram stat or tab mebendazole 500 milligram stat or 100 milligram twice a day for 3 days should be given. In those cases where there is a lot of hookworm infection, we need to repeat this after 12 weeks. Anemia Mukt Bharat 2018 has brought a major change in the management of this parasitic infection by including tab albendazole 400 milligram to all antenatal patients after the first trimester. So that's about diet. Next, we look at drugs in the management of iron deficiency anemia. The drugs include the oral drugs, the oral iron tablets, and the parenteral drugs. The iron salts could be either inorganic salts or organic salts or elemental iron or chelated iron. As compared to ferrous salts, ferric salts are much less well absorbed. Now, what are the factors that affect oral iron absorption when we give them in the form of tablets? It is the dose, that is the amount of elemental iron present, the stability in gastric acids, and the bioavailability, the status of the patient's iron storage, and the form that is administered. All these make an impact in the amount of iron that is absorbed. Oral iron has been used to treat iron deficiency for centuries and should always be given preference over parenteral iron as the initial approach to treatment. So in all cases, oral iron has to be given. WHO recommends the ferrous form instead of the ferric form or over the ferric form because the ferrous form has got good bioavailability, its acceptable tolerability and high effectiveness make it enduring for the treatment of iron deficiency anemia. Now, as far as oral iron is concerned, the absorption increases with increasing doses of oral iron. But it doesn't mean that you go on increasing the number of tablets of iron she needs to take per day. This happens only up to 160 milligrams per day. Any increase above this will not increase the absorption of oral iron, but it only increases the amount of gastrointestinal side effects. Entry-coated and delayed release preparations have proven to have very poor bioavailability. Iron tablets should be taken on empty stomach or 1 hour after meals for better absorption, preferably with vitamin C rich products such as orange juice or with a guava. GI side effects, which include nausea, constipation, diarrhea, indigestion, and metallic taste, are due to the reduced gastric motility and gravid uterus. We need to advise to reduce the dosage, change the preparation, or take with meals if GI symptoms occur. If a woman, which is most often we find women complaining of the gastrointestinal symptoms with iron, and in those women, we either need to change the dosage or change the preparation itself and ask them to take it with meals, of course, with a decrease in the absorption of the amount of iron. Assessing the response to oral iron. Now, once we have given iron tablets, how do we know that there has been any improvement? Basically, there is an improvement in symptoms. She starts feeling much, much better. There is an improvement in the mood, irritability within the next 24 hours, because iron is not just required for hemoglobin, it is required for the various enzymes and for the functions of various cells in the body. It increases the appetite, it makes the woman eat better, increases the reticulocyte count after 7 to 10 days, and the rise in the hemoglobin after 2 weeks, at least by 1 gram, a deciliter per week. Now, supposing we do check the hemoglobin, we find that the rise is not as what we expected it to be. Then we need to check on the compliance, see whether the woman is taking the iron properly, reconfirm the diagnosis. Many a times it may not be iron deficiency anemia, it might be some other problem. Consider parenteral iron in some women. Now, once the hemoglobin is normal with the treatment, we need to continue. Do we stop at that just because the hemoglobin has come to normal? No. We need to continue 100 to 200 milligram per day for 3 months. And not just that, even after she delivers, we need to continue iron at 100 to 200 milligrams per day for 6 weeks postpartum. We need to give 60 to 100 milligram per day for 6 months postpartum in those where it has been very much normal. Now, the next aspect is the intravenous iron. Intravenous iron scores over oral iron in certain situations because there is complete bioavailability of the iron that has been administered, the fewer gastrointestinal side effects, and the recovery of hemoglobin is much faster with an intravenous iron because it is simple, it is safe, and it's very sure way of administering iron. On the other hand, there is an increased risk of oxidative damage because of iron-free radicals, increased cost, and the small but finite risk of hypersensitivity reaction to the iron preparation. Now, parenteral iron preparations have gone through several generations. We have about 3 generations of iron preparations. The first generation was iron dextran associated with rare but serious allergic reactions that could lead to anaphylaxis. Those were the intramuscular injections we used to give when we were postgraduates, painful staining of the buttocks and required multiple injections, and hypersensitivity reactions were many. The second generation preparations were, of course, the iron gluconate and iron sucrose. They may only be administered in low doses because of the labile iron complexes. In fact, iron sucrose brought about a major change in the incidence of anemia in our country. However, there are more chances of free iron release and subsequent toxicity if given in higher than recommended doses. Therefore, there is some limitation to this iron sucrose. Then came the third generation of parenteral iron, which is the ferric carboxymaltose, iron isomaltoside, and ferromoxitol. They have unique, strong, complex structure. They release much lower levels of labile or free iron. Therefore, the chances of oxidative damage is much less, and they allow for large doses of iron, which can be given over shorter time period. Now, going back to the intramuscular iron, the Ministry of Health and Family Welfare recommended the use of intramuscular iron after testing as cost-effective therapy for moderate anemia and pregnancy. However, like I already said, this inconvenience of painful injection, dark discoloration, arthralgia, myalgia, hypersensitivity, etc. So it has fallen out of repute. Ferric carboxymaltose, FCM, is type 1 robust parenteral iron. It's not associated with dextran-induced hypersensitivity because it's dextran-free. It can be administered in much higher doses, almost 1000 milligram, short infusion time, minimum about 15 minutes. The iron is released slowly, so there's no free iron that is available, and therefore toxicity and oxidative stress is reduced. The structure is similar to ferritin, and it is deposited easily in the reticuloendothelial cells. With ferric carboxy maltose and all the third generation of parenteral iron, test dose is not required, and it has got very low immunogenic potential. So I would say that ferric carboxy maltose is one which has really made a lot of difference in the management of anemia. The newer preparations include ferumoxytol, which is available here, which is not available here. FDA approved in 2009, type 1 complex, immunological reactivity. The dose is 510 milligram over 15 minutes, and it needs to be repeated after 1 week if it is required. Intravenous iron, newer preparation includes iron isomaltoside. It is available in India. 20 milligram per kg infusion can be given in 1 hour. Of course, it has got immunogenic potential. There's no significant hypophosphatemia. Unlike FCM, FCM initially had this concern that there could be significant hypophosphatemia, and that is why it was not used during pregnancy in the earlier stages when it was introduced. But it is superior to FCM. Iron isomaltoside is superior to FCM in iron deficiency anemia. The rise in hemoglobin is much faster and a little higher. Now, the prerequisites for parenteral iron therapy includes confirming the diagnosis of iron deficiency anemia, adequate supervision for management of anaphylactic reactions. We need to stop oral iron at least 24 hours prior to therapy to avoid toxic reactions. Watch for reactions like chest pain, rigor, chills, hypotension, dyspnea, hemolysis, and anaphylaxis. Calculating the dose of parenteral iron, it's very simple and easy. 2.4 into the difference in hemoglobin percentage, target minus actual, into pre-pregnancy weight, adding another 1000 milligram for the replenishment of the iron stores. Dose can be titrated according to available iron stores, history of ongoing blood loss, and hemoglobin response. The treatment of the last aspect of the treatment of iron deficiency anemia in pregnancy is blood transfusion. Indications for blood transfusion in pregnancy with iron deficiency anemia include pregnancy less than 36 weeks, where we don't have enough time to build the hemoglobin with just the iron preparations. Hemoglobin less than 4 grams per deciliter with or without signs of cardiac failure or hypoxia. 5 to 7 grams per deciliter with the presence of impending heart failure, hemodynamic instability, or acute hemorrhage. Those are situations where definitely we need to give blood only. Pregnancy more than 36 weeks, hemoglobin more than 7 grams per deciliter, even without signs of cardiac failure or hypoxia. Severe anemia with decompensation or acute hemorrhage with decompensation. Hemoglobinopathy, bone marrow failure syndromes, or malignancy. These are some of the situations where blood is transfused during the antepartum period. During the intrapartum, when the hemoglobin is less than 7 grams per deciliter, the decision of blood transfusion depends upon the medical history and symptoms. Severe anemia with decompensation or acute hemorrhage with decompensation. In the postpartum period, anemia with signs of shock or acute hemorrhage with signs of hemodynamic instability, hemoglobin less than 7 grams, the decision of transfusion depends on the medical history or symptoms. So all that I can say is blood transfusion is in a situation which is very acute when there is either hypovolemia or when the hemoglobin is very less than 7 grams. Because the risks of blood transfusion include hemolytic transfusion reaction, transfusion-associated sepsis, anaphylaxis, TRALI, and many. It can be very costly. The life that we wanted to save can itself be lost because of a transfusion reaction. Therefore, we have to be very careful. Each blood product transfused carries a small risk of an adverse effects. So we need to recognize, respond to, and report such adverse effects. This is a pictorial representation. Hello. The first trimester, second trimester, and third trimester, all that we need to do here is to make sure that we check the hemoglobin, whether it is more than 7, less than 7. And if it is more than 7, we have time. So we can, and in early pregnancy, we can treat with oral iron preparations. In situations where oral iron preparations are not enough to bring the rise in the hemoglobin, or if it is later in pregnancy, then we need to either give parenteral iron, or if the hemoglobin is very less, we need to give blood transfusions. So let us look at the management, obstetric management of iron deficiency anemia and pregnancy. In the first stage of labor, a woman who is anemic needs to be in a propped up position. I think all women need to be in propped up position. Oxygen should be given SOS. Adequate cross-match blood should be available. Adequate analgesia and antibiotic prophylaxis because she is susceptible to infection. Strict asepsis should be maintained. We need to monitor for the signs of pulmonary edema and restrict IV fluids. In the second stage of labor, if labor is progressing well, fine. Otherwise, we might have to cut short the second stage of labor with the use of instrumental delivery. And in the third stage, the most important stage where we need to practice active management of third stage of labor, AMTSL. Now, delayed cord clamping for the prevention of iron deficiency anemia in the offspring is some add-on for this particular talk. It is not relevant to the woman herself, but we must remember that every woman started off as a neonate. About 30% more blood flows into the baby and adds 50 milligram of iron to the baby's iron stores. So delayed cord clamping is very important. It means clamping the cord 1 to 3 minutes after the birth or when cord pulsation has ceased. It's just a matter of a minute, but it can make a huge difference. In the postpartum period, we need to check the hemoglobin of all women 48 hours after delivery. Mild anemia between 10 to 10.9, treat with oral tablets for 6 months. Moderate anemia, treat with IV iron. And severe anemia or hemodynamic compromise, treat with blood transfusion. We have come a long way since NFHS 2005 to 2015, where 57.9 was the incidence of prevalence of anemia. It came down to 50.3. It might look a very small number, but it has made a huge impact to the overall incidence. Anemia eradication can become a reality because our government has taken a huge step in making sure that we have an Anemia Mukt Bharat, introduced a whole lot of programs in order to make sure that our country is devoid of anemia. Let's make use of any opportunity to address anemia. In fact, create opportunities to do just that. This is about Anemia Mukt Bharat. Our intention is to bring down the incidence of anemia from 50%, which was in 2016, to just about 32% in 2022. So let's stay strong. Iron strengthens. So we all need to commit ourselves to conquer this iron deficiency and make a very strong pledge to eradicate anemia from our country. Thank you very much for a patient hearing.
Thank you so much, ma'am, for your wonderful presentation. It was really concise. And now I welcome Dr. Manju Shukla, ma'am. Ma'am, please introduce the next speaker, Professor Krishnendu Gupta, sir.
Good evening. First of all, I want to thank Preeti for giving me this opportunity. And it is my proud privilege to introduce Krishnendu to this forum. He was very upset yesterday. He is very busy. And thank you, Krishnendu, for giving time for from your busy schedule.
नहीं मैडम क्या बोल रहे हैं?
Dr. Krishnendu needs no introduction for FOGSI Forum. He is FIC MCH, FICOG, FRCPI Dublin, FRCOG London, MBBS Mangalore, DGO Manipal, MD Manipal, Professor and Unit Head Department of OBGY, Vivekanand Institute of Medical Sciences, WBUHS Kolkata, Adjunct Professor Department of OBGY Kasturba Medical College, MAHE Manipal, 2017 to 2022. FOGSI representative to Asia Oceania Federation of Ops and Gynae, AOFOG 2022. Chair
Madam,
Secretary.
ठीक है, Madam. We are running a little late. Thank you. We'll start, I think. Thank you. Don't worry.
He is going to talk on a mega subject, megaloblastic anemia, which has been talked very less and diagnosed very rarely. So, Krishnendu, how to manage this megaloblastic anemia?
Well, thank you very much, Manjuji. It's really a long time that I know you, Chandravati ji. I've really been blessed by all of you, and I thank the Safe Motherhood Committee, Dr. Preeti, the entire vibrant team for giving me this opportunity, and of course, wonderful work done by our respected President, Dr. Alpesh Gandhi, and Meera ji also, my pranams. So the topic today, of course, is the management of megaloblastic anemia. And I also thank additional Professor Aparna for her help in these slides, a wonderful module that she has prepared for the Safe Motherhood Committee, which really made my life very simple. So what is megaloblastic anemia? It encompasses a heterogeneous group of anemias characterized by the presence in the bone marrow of large red cell precursors called megaloblasts, and it's also because of the impaired DNA synthesis, this further inhibits a nuclear division. But what escapes is the cytoplasm. The cytoplasm maturation, which is dependent on RNA and protein synthesis, is less impaired. So therefore, there is an asynchronous maturation between the nucleus and cytoplasm of the erythroblasts, explaining the large size of the megaloblasts. The process affects the entire hematopoietic system, hematopoiesis rather, the bone marrows, etc., but also the rapidly renewing tissues, that is the one in the gastrointestinal system. And it's obviously most often due to hypovitaminosis, specifically vitamin B12 and folate, which are the necessary synthesis of DNA. Now, what about macrocytosis? It's a morphological term that describes large RBCs in the peripheral blood and includes all the anemias with a high mean corpuscular volume. It is a specific, so you have megaloblastic anemia, which is actually a specific subtype of the macrocytic anemia. There are various causes of macrocytosis, which is abnormalities of DNA metabolism, primary bone marrow disorders, lipid abnormalities, and of course shift to a mature cell. But I think what we are really focused on are these two, the vitamin B12 and the folate deficiency, but also we cannot forget liver disease, hypothyroidism in our country, and of course the action on the erythropoietin, and of course very rare aplastic anemia that's also seen once in a while. So the clinical presentation is, there's worsening of the macrocytic anemia. If anemia is combined with jaundice, you get yellowish color, discoloration of skin. Well, neurological manifestations are rather rare nowadays, but if there is cognitive slowing or signs of neuropathy, you have to think of vitamin B12 deficiency. And of course, we all know the dreaded problems of the neural tube defects if there is preconceptional folic acid deficiency. So we have to suspect someone having megaloblastic anemia if there is unexplained anemia with macrocytosis, pancytopenia, and of course, in the peripheral blood smear, which I'm going to come to a little later, presence of hypersegmented neutrophils. There's unexplained neurological or psychiatric symptoms, a strict vegan diet, which is now becoming very, very popular all over the world, or in conditions that may interfere with absorption, GI symptoms like sore tongue, anorexia, and or diarrhea. And we have to have a history, of course, the previously diagnosed conditions like celiac disease or inflammatory bowel disease, bariatric surgery, very important in the modern era, intestinal surgery, reduced dietary intake, which I just told you about, alcohol abuse, and that's why liver disease and alcohol abuse, and of course, subtle neurological or psychiatric symptoms, which you just should not rule out the possibility. Clinically, usually they are normal. We have to look for the GI and the skin findings, as I mentioned, hepatosplenomegaly, lymphadenopathy, and neurological examination is important. We have to rule out any signs of any neuropathies. Lab testing, of course, the complete blood count and the fetal blood smear, you will find definite problems of anemia. But what is important is that both the folate and the vitamin B12 deficiencies, they are identical findings. Of course, you'll find macrocytic RBCs mild leukopenia with or without thrombocytopenia, a low reticulocyte count. But what really clinches the issue are these hypersegmented neutrophils on the peripheral blood smear. That is more than 5% neutrophils, or with more than 5 lobes, or at least 1% of the neutrophils with more than 6 or more lobes. And this is what is a normal smear. As you can see, that the diameter of normal RBC is equal to that of the nuclei of the lymphocyte, okay? And the central platelet should be about 1/3. Several platelets are also seen, and red blood cells are of uniform size. Well, in a vitamin B12 deficiency, you have these macroovulocytes and these teardrop cells, which are basically the advanced forms of macroovulocytes. Then you have the peripheral blood smear, which I was talking to you about with the hypersegmented neutrophils. In this, there's 7 lobes. Again, you have macroovulocytes, and they precede, of course, the development of anemia and may be present as isolated findings without anemia as well. Well, interpretation of MCV, we are always very worried whenever we see those many of these MCV, MCHC, so many things being highlighted. Of course, the value, if it's more than 115 femtoliters, and there's more specific to vitamin B12 and folic deficiency. However, a normal MCV does not exclude vitamin B12 or folate deficiency, and that's why it's really difficult to diagnose. So we have to go in and do the direct test. So MCV does not help distinguish vitamin B12 deficiency from folate deficiency. If a patient has concomitant microcytosis due to iron deficiency anemia or thalassemia, the macrocytosis may be masked as MCV reflects the average volume. And you saw in detail how Dr. Shushila Rani explained everything about iron deficiency anemia prior to me. So the additional features, the megaloblastic anemia can cause premature destruction of developing RBCs in the bone marrow. So there's ineffective erythropoiesis, there's leading to intramedullary hemolysis, and of course there is hemolysis in the peripheral circulation as well. The laboratory finding associated with hemolysis, of course, increased LDH. Nowadays with COVID, I think all of us are very, very worried about LDH, increased indirect bilirubin, low haptoglobin, and of course we have to note that reticulocyte count is low, unlike the other forms of hemolytic anemias. Well, serum vitamin B12 estimation is important. Above 300, we are very happy. 200 to 300, of course, is borderline, and less than 200, we are definitely, it's low and consistent with deficiency. And of course, additional testing may also help determine the accuracy of diagnosis and its cause. The pitfalls is that in pregnancy, the levels are spuriously low, decreased production of vitamin B12 binding proteins. And of course, in certain disorders like of the kidney and occult malignancy, there are really spuriously high levels of vitamin B12. Coming to folate deficiency, we know the levels, 4 nanograms per mils is normal, and 2 to 4 is borderline, and less than 2 is definitely consistent with folate deficiency, and we have to be careful about that. And there's of course, additional testing of methylmalonic acid and homocysteine, which can also be done. Of course, this is a little busy slide, how to kind of interpret the additional tests of MMA and homocysteine, and I think for kind of want of time, I think I'll skip it because we're already running a bit late. The other tests, of course, which are not done, the Schilling test and the RBC folate test, the intrinsic factor antibody test is done for pernicious anemia, and of course, how to know the replacement to vitamins replacement. That we must. It is usual that the hematological response can be assessed by measuring the reticulocyte count and CBC before and approximately 2 weeks after supplementation. So that's something to remember. The general principles of treatment, of course, how important, how urgent it's required for the correction, repletion of the vitamin, deficient vitamin can be instituted over a period of weeks. The routine of the route of administration, of course, again, depends whether it's orally or parenterally, depending on the symptoms, whether it's because of whether it's mild or severe, and if there's any decreased absorption. So if there's severe symptoms and there's kind of some celiac disease and intestinal issues, you have to give parenteral, and dietary deficiency, of course, is oral. And the adverse effects, water soluble, generally no side effects because it's water soluble. But something I really learned from the presentation, and I had a discussion with Professor Aparna today, is that additional supplementation in non-deficient individuals, if you keep pumping them with folic acid more than 1 milligrams per day, of course, you can have developmental delay in children. And the treatment of vitamin B12 deficiency, we know it's parenteral or oral. Parenteral 100 micrograms, parenterally once per week until the deficiency is sorted, and then once per month, that's cyanocobalamin and or every 1 month by hydroxycobalamin. Hydroxycobalamin, as you all know, can also be used for the treatment of cyanide poisoning. Well, orally in adults and with normal absorption, oral dosing is equally effective at a dose of 1,000 micrograms per day, and we are quite happy prescribing vitamin B12 tablets nowadays, because with methylcobalamin, this methylcobalamin being available in 500 microgram tablets quite readily, unlike what it was earlier. So again, the decision between parenteral and oral therapy whenever there's severe disease and whenever there's any GI issues. But in a Cochrane review in 2018, which included 3 small trials with a total of 153 patients, they compared oral versus intravenous vitamin 12 in individuals with vitamin B12 deficiency, and they suggested that both the routes were effective in raising vitamin B12 levels. Well, to treat folate deficiency, oral folic acid 1 to 5 milligrams daily, and this is kind of more than sufficient, even if there's malabsorption, because the dietary, because it's far excess what is required than the kind of routine dietary allowance of 200 micrograms, which is 0.2 milligrams. So another problem is what happens is folate deficiency masks the B12 deficiency. So folic acid can actually partially reverse some of the hematological abnormalities, but is never used for the treatment. However, neurological manifestations of vitamin B12 deficiency are not treated by folic acid, as I just mentioned. So therefore, folic acid can mask the untreated vitamin B12 deficiency or even worsen the neurological complications. So a clinical practice point is whether you test for and treat a vitamin B12 deficiency, it must be appropriate that we test as well as treat vitamin B12 deficiencies, even if it's not warranted to do so, because of the problem of the masking of folate masking the vitamin B12 deficiency. So how do you monitor the response? So the markers of hemolysis, they should decline in about 1 to 2 days, LDH and indirect hemoglobin. Evidence of new blood cell production should occur within 3 to 4 days. That means an increase in reticulocyte count. The anemia starts improving at about 1 to 2 weeks, normalizes between 4 to 8 weeks. The presence of the hypersegment neutrophils, which were there, they should start disappearing and should disappear by 2 weeks. And the leukopenia or thrombocytopenia should resolve within about 2 to 4 weeks. So how often do you monitor, and what should be the intensity of monitoring? So we should repeat the complete blood count and measurement of the deficient vitamin at about 2 to 4 weeks. And we must monitor to continue till completion of the desired response, as I just mentioned in the previous slide, and re-evaluate the complete blood count and or the vitamin B12 or folate levels within 3 to 12 months of stopping therapy. Coming to, we have a lot of problems with not only compliance, but we have to also verify that the correct vitamin was taken. We have to switch from oral to parenteral therapy if definitely there are concerns about absorption. I think this is the 3 times that I've repeated it, and that's so much important because most of the patients will not be compliant if they feel that there's no kind of improvement after a while. We repeat the diagnostic testing, and if required, we have to do additional testing for other causes of anemia and also rule out hypothyroidism and other syndromes. So quick recap. Megaloblastic anemia, the most important 2 causes are lack of vitamin B12 and folic acid. And of course, we know that it is caused because there's a process of nucleic acid metabolism that is impaired. There is the nuclear and the cytoplasmic dyssynchrony because the cytoplasm doesn't get impaired that much compared to the nuclear growth. And of course, there's reduced number of cell division in the bone marrow. The nuclear abnormalities in both the myeloid and the erythroid precursors are hampered. And of course, in the peripheral blood smear, you have presence of hypersegmented neutrophils and macroovulocytes. And of course, do not forget these tear cells as well, which are basically macroovulocytes seen in vitamin B12 deficiency. So to summarize, all individuals with documented vitamin B12 and or folate deficiency should be treated. The dose of vitamin B12 is 1,000 micrograms by deep subcutaneous or intramuscular once daily or for 1 month, followed by 1,000 micrograms once per month. And the folic deficiency or the folate deficiency, folic acid deficiency is treated with oral folic acid and given 1 to 4 months till hematological recovery. And the typical response to correction includes and initial reticulocytosis over 1 to 2 weeks, followed by the resolution of anemia in about 4 to 8 weeks. So thank you very much for this opportunity, and I hope that in the last 10 minutes, I hope to have saved some time for the organizers. And thank you for this opportunity once again. And that's it. Thank you.
Thank you, sir. Sir, you really stick to the time, and it was really a nice presentation. Message was very clearly delivered. Thank you, sir.
I think I must thank Dr. Aparna for this.
Yeah, we'll convey, sir. She's also here.
Yeah.
So now I request Dr. Lakshmi Shikhande ma'am to invite our next speaker, Dr. Milind Shah.
Very good evening to one and all. Kudos to Safe Motherhood Committee, FOGSI, headed by Dr. Preeti, for having this wonderful initiative and joining hands with Government of India for anemia eradication. She has carefully chosen the important topics related to the subject, that is anemia. And what I was appreciating more, Dr. Preeti, is that you have prepared the slides on each and every topic, which is much needed, because these slides will be conveying the uniform message from FOGSI to all the members across India. So hats off to you. Now, after listening to iron deficiency anemia and megaloblastic anemia from two great stalwarts, Dr. Sushila Rani and Dr. Krishnendu, now it is time to invite yet another very eminent speaker and dear friend of mine, Dr. Milind Shah, who will be speaking on postpartum anemia. Friends, as soon as a baby is born, each and every member in the family, including the newly born mother, they all start neglecting the mother's health. But as an obstetrician, we cannot afford to neglect her. So let us hear from Dr. Milind Shah what he has to say about the management of postpartum anemia. He is currently consultant at Naval Maternity and Nursing Home based at Solapur, having one hospital at Mumbai, and he is expert in endoscopy and IVF. Friends, he has got n number of publications, he is a prolific orator and a great academician. So Dr. Milind, floor is yours.
Thank you very much, Lakshmi, for your kind words. Let me share my screen, please. Yeah. Yes. Is it seen? My screen is seen there?
Yes, sir. Very clear. Yes,
yeah,
sir.
Yeah. Thank you very much. At the onset, let me thank the Safe Motherhood Committee, Dr. Preeti Kumar. And what I have noticed that, the committee chairpersons keep on changing, but the zeal with which all chairpersons they work is really, really praiseworthy. And Preeti, you have done a mile, actually another stone in this particular travel, which is really remarkable. And I was seeing that all your members, all your friends, all your society members so actively got involved in this particular travel that I'm very sure it's going to go a long way for our women who come from very small places, who are anemic, who have so many problems. For example, this story of Karuna. Again, the same situation. She was very low socioeconomic strata, coming from one slum area. And as you can see, the anemia is a curse. She's always, having that. That's why I always like to remember this particular actually quote by Mahatma Gandhi. If blood is shed, let it be our own. Let us cultivate the calm courage to die without killing. And that's how actually the obituaries need to do whenever they are dealing with the women, and basically to address this anemia very, very seriously. I still remember this satellite school which we had conducted, put so much actually questions from the postgraduates, and I was so happy that they're going to go a long way. And especially in this COVID scenario, again, things are more worse. We have reduced our antenatal visits, and naturally there is more and more chances of postpartum anemia. But question comes how to define it. And there is always a lot of controversy in different schools, different actually the clinics as well as different clinicians. But we need to take into consideration certain factors about disappearance of hemodilution, which we see at delivery, where we know that there's increase in the plasma volume compared to the red blood cells, and the postpartum induced rise in the hemoglobin. If we assume that woman is not iron depleted, has a singleton pregnancy, and that peripartum blood losses are slight to moderate, that is less than 300 milliliter, there is increase in postpartum hemoglobin concentration. But that rarely happens for a variety of reasons. We all know that, and that's why there's a difference in the mean hemoglobin between the supplemented and non-supplemented women 1 week postpartum. Also, mean HP after 8 weeks postpartum was 13.1 in the various studies. But what actually I have noticed in my clinical practice, it's never a story. Though they say 10.5 gram, I always find it is less than 10 gram. And that's why this cutoff need to be decided as per the standard actual definitions. The cutoff value for anemia 1 week postpartum should be identical to value of anemia at delivery, that is 11 gram, and 8 weeks it should be 12 grams. Suppose we adhere to these actually levels, I'm very sure we'll be little more aggressive in addressing this postpartum anemia and little more serious as well while treating it, which is very, very important. Suppose we look at the prevalence, it has been reported to be between 30 to actually 70%. Why it is so? Because of variety of reasons. The significant factors identified as risk factors are anemia at 36 week gestation, the younger age of the mothers, and inadequate iron supplementation during a postpartum period. And that's why one need to be very, very careful to know these causes of postpartum anemia. We need to treat this iron deficiency well in advance before she delivers to avoid this problem of postpartum iron deficiency. Sometimes it is combined with that acute bleeding, which contributes to this particular anemia. And the other factors that may contribute could be, as Krishnendra was saying very correctly, the other vitamin deficiency. It could be the inflammation, infectious disorders, which can cause little more actually anemia in that particular given woman. And the other risk factors for iron deficiency are low socioeconomic status, multiparity, and women with multiple pregnancy are especially at risk because of the obvious reason of getting little more actually blood loss. What causes this postpartum anemia? But you ask me what I have noticed in my practice, quite few of them, they are getting postpartum blue rather than anything else. I have seen certain doctors, I have seen certain professionals who delivered with us and having anemia always had some sort of postpartum psychosis when they were anemic and what not very serious about their hemoglobin status. It decreases the physical performance. It increases prevalence of tiredness, breathlessness, palpitations, and infections, particularly in the urinary tract. And that's why one need to think of anemia whenever we get the puerperal sepsis as well. I still remember in old days in 1980s, one of our professors used to say whenever case of sepsis used to come, give one blood transfusion and she will recover. Of course, the science has changed a lot now and we understood the problems of blood transfusions. We are not practicing that, but the understanding was that anemia, which could be contributory for this sepsis part of that particular postpartum status. It reduces the cognitive performances, induces emotional instability and distress, and increases the risk of postpartum depression. This one need to actually very seriously take whenever we find these presentations in front of you in the postpartum period. It impairs the mother to child interaction and iron supplementation protects against negative effects. Women experience difficulties in caring for the newborns and managing the bond between the mother and baby get disturbed. This significant contribution to the maternal mortality as well. Suppose she gets infection and anemia, quite often it is causes a lot of problems in the postpartum period. About the breastfeeding, people always say that it causes loss of 0.3 grams milligrams because of breastfeeding, and we need to correct it with the other losses. But also think about the baby as well, because it has been said that each month of the breastfeeding beyond baby's first birth increases the risk of iron deficiency by about 5%. And the children who are breastfed for longer than a year were estimated to have 1.7 times the odds of being iron deficient than those breastfed for the less than a year. So one need to address this part also very seriously. And as a working in the perinatology group, I realized this also need to be taken very, very seriously. Now coming to the management, what are the tips? The iron supplements doesn't need much emphasis, but we are going to see how practically we can implement that in our day-to-day work, how we can improve the levels of iron in our body by taking iron supplements, eating food rich in iron, that has been told very nicely by Dr. Sushila. You can consume iron-rich foods. Again, whenever we tell that, one need to understand the socioeconomic status of that particular lady. Otherwise, suppose you say something very fancy to her, she may get more depressed as well. Giving jaggery, dates, and green vegetables itself is a quite iron-rich food, I would say. Reducing the tea consumption, vitamin C supplementation, or taking adequate citrus foods. High fluid consumption. You know, there is a myth in the Maharashtra. I don't know what is there in the other part of country, but they say after delivery they should take very less water or the liquid because it causes some problem in the stomach of the baby, and quite often they get a lot of problems, not only the anemia but also they get the TVT and sometimes the some cranial problems. So one need to very seriously think about giving good fluids consumption, stool softeners to avoid the loss from the piles or anything else, risk of infection, and of course resting well. This is a very take-home message one need to give to all our delegates, that it's a story which is very commonly seen in each hospitals. Like nowadays, they always find 7 to 8 people coming, greeting with bouquets, gifts, cards, and that lady, she says, "No, I want to relax." So resting is very, very important. Now coming to the iron requirements, we know that the iron in entire gestation is average 4.4 milligram per day, and the first trimester 0.8, third trimester 7.5, but net iron loss also need to be thought about. In postpartum period, after normal pregnancy and delivery without iron deficiency, before resumption of the menses, the requirement definitely declines. But there is obligatory iron losses of 0.8 milligram plus losses of, as I told you, breastfeeding 0.3 milligram per day, and period with the low iron requirements one need to think about, but can be covered with dietary intake. But we all know that it is not very easy to say about this dietary supplementation, because all said and done are actually women. They live in different socioeconomic strata and they have their own limits as far as the dietary correction is concerned. And that's why we always and always propagate the iron supplements even after delivery, which is very, very important. Magnitude of peripartum bleeding exceeding more than 300 milligram leads to rapid depletion of the body iron reserves and induces the acute anemia. Sometimes it can be very severe as well, compromising the CVS function, that need to be again tackled very seriously. Larger the blood loss is, the larger the iron requirements for the mother in lactation period. The blood loss of 500 ml contains 203 milligram of iron. With the dietary iron intake of 9 milligram per day, even with maximum absorption, dietary iron will not be adequate to compensate this in the postpartum period. And that's why, apart from dietary modification, one need to think about the various other iron preparations. Could be oral, could be intravenous, or could be also thinking of obstetric prophylaxis and treatment of postpartum hemorrhage. Diet, we all know. Fortunately, yes, we have actually the good amount of a four-square diet, which we call in our Indian community. But still, there are certain actually the restrictions in different communities in India, whereby they restrict by saying we give only rice. They say we won't give any spices. The another community says we give only the wheat, and all that need to be corrected. We need to tell them that there should not be such a restriction. She should have actually the all dietary contents in her diet. Now regarding the iron supplements, there are too many options available now. Fortunately, those was not the actually cases in 1980s when we were doing our post graduations, and we had a limitations, as Sushila was telling about that very painful injectable iron or the oral iron. But now the apart from oral iron, we have so many other options which we need to use very judiciously by selecting the cases accordingly to see that her postpartum anemia status is well corrected. And all said and done, there are so many such placebo control studies whereby you can see that the anemia level was 14% in the anemia, the corrected or the supplemented cases compared to 22% in the placebo group. And at 8 weeks postpartum, it is 6% versus 16%. And that's why one need to see it accordingly. Now, again, many people ask, what about the multivitamins and the mineral supplementations, which taken with meals is very, very low. But iron should be administered in separate tablets taken with the meals in order to ensure an optimal absorption. The IV iron is reliable modality for the management of moderate anemia in third trimester. This also prevents progression of postpartum anemia as well. And that's why whenever we need to give the prophylaxis, obviously prophylaxis and treatment of postpartum hemorrhage, evaluation and treatment of disorders that predispose to the peripartum bleeding, postpartum hemorrhage and postpartum anemia need to be sought about. And that's why giving one tablet of antihelmintic is again very important intervention, I would say, because it causes more absorption as well as the avoiding the postpartum anemia. To reduce the frequency of both expected and unexpected complications of bleeding in the delivery process is again a part of preventive approach to avoid postpartum anemia. Now, many people ask, do you do routinely the hemoglobin status after delivery? It is not a routine practice, but we do it. When we do it, we actually always do it 1 month postpartum, but all those cases of multiple pregnancies, the cases with anemia, we always prefer to do it 1 week postpartum to identify what actually is happening in that particular body. The CDC recommends selective screening for anemia at 4 to 6 weeks postpartum in women who had anemia continued throughout the third trimester, the women who got excessive blood loss, and the women with multiple pregnancy. Although routine, the iron deficiency, the iron supplementation after delivery is advisable, HB is advisable in women with antenatal anemia or the PPH. But this approach always goes a long way. Now treatment, the mild symptomatic women can be managed with oral iron with 100 to 200 milligram per deciliter for next 3 months. But if the optimum levels are achieved, you can come down to 100 milligram as well. The moderate anemia need to be corrected with IV iron, and the severe anemia or evidence of hemodynamic compromise, transfusion prior to discharge from healthy facility is very, very important. But one need to be very judicious about this BT while giving postpartum. Wherever there is a need, as it is very clearly mentioned with the hemodynamic compromise, need to be understood very clearly, and one should not advocate the blood transfusion to even the moderate or the severe cases if you can correct the things by giving the injections or the iron injections. Whenever feasible, a follow-up CBC with serum ferritin should be considered before discontinuation of iron therapy at 3 to 6 months. As I told you, one need to also see that the absorption is optimized and the reducing the GI side effects, which are sometimes seen in some of the patients where we give oral iron. If improvement, therapy continued during the remaining postpartum period, subsequent check of hemoglobin and ferritin after 8 weeks, and when HB has reached to a level of 12 or more than 12, you can reduce the dosage as well. But quite often we see the failing responses as well. The non-compliance due to psychological mechanisms, due to gastrointestinal side effects. Again here, the role of baby plays very much big role. They say by taking those tablets, the baby will get pain in abdomen. And that myth need to be dispelled very strongly when you are speaking with your patients. The impaired gastrointestinal absorption also need to be thought about. If you find there's no much improvement, and one can take the help of our GI actually specialist friend to overcome these particular problems. The prolonged late postpartum uterine bleeding with continuing iron losses again need to be addressed. Quite often, I have seen many of the times this particular complaint is dismissed by saying that ऐसे होता ही रहता है. No, not really. We need to understand as OBGYN, this is not correct. We need to see why she's bleeding for longer duration in the more quantity after delivery. There could be some small missing cotyledon. There could be something like, small pieces of the membranes which need to be taken correctly when we are addressing this particular postpartum anemia. And women who do not respond to oral iron therapy should be considered. And there are a lot of actually changes, and especially by getting this new generation preparations available like ferris carboxymaltose, there is a lot of change in the practice. We had so many other preparations, rather do have other preparation with it as well. The iron sucrose, low molecular weight iron dextran, ferric iron carboxymaltose, and the ferric iron isomaltoside 1000. But two of the things are very commonly practiced in our India, iron sucrose and the ferric iron carboxymaltose. People always say, how you're going to choose it? It depends on the patient's compliance, economic status, as well as to see that what she is going to prefer out of these two. But iron carboxymaltose always gives better actually the compliance and the better or the faster results in the hemoglobin concentration. The IV iron administered as a total dose infusion, which is replenishment of this body iron reserves within few days. And the total dose of iron needed to be to correct anemia, and also to think of the stores as well by, as usually we do with the modified Ganzoni formula. There are certain worry about the adverse effects while giving these injections. The frequency is very, very low. It is less than 0.5%. Infusion should be given in setting where equipment for the cardiopulmonary resuscitation is available. Infusion should be given in the peripheral veins. The third generation preparations, as I told you, has a lower frequency of side effects compared to the iron sucrose or the second generation preparations. But
excuse me, sir, just please, if you can just
sum up. This last, I think 3 or 4 slides, I'm going to sum up my talk. The indications of IV postpartum, as the first option is profound IDA with the hemoglobin level less than 9. A second option in moderate anemia with hemoglobin level 9 to 12 and fails to increase by oral iron. The dosage, again, we all know about it, how to calculate, how to give it, and all those actually the facts about the iron sucrose as well. But lastly, I would say, if it is a profound anemia with hemoglobin level less than 6, think about BT, or if the patient is hemodynamically unstable. In women who refuse blood transfusion, again, we'll have to think of all other options. So the major causes of postpartum anemia are antepartum iron deficiency in combination with excessive blood loss. Bleeding exceeding the normal blood losses may lead to rapid depletion of iron reserves and may lead to long-standing iron deficiency and iron deficiency anemia in the postpartum period. The major causes of anemia are antepartum deficiency, bleeding exceeding the normal blood losses, and prophylaxis begins with iron supplements in the pregnancy and by performing obstetric prophylaxis measures in pregnancy at risk of complications. Treatment of the mild to moderate deficiencies, first choice should be oral, otherwise iron, depending on, as I told you, all those factors which we saw. And last option is the blood transfusion whenever required. Thank you very much. Thank you, Bhavana, for this extra 1 minute. And thank you very much for patient listening. Thank you very much.
Thank you, sir, for your wonderful presentation, and quite a good message clearly is delivered. And now I would request our chairperson, Dr. J.M. Kannan ma'am, to please give your expert opinion on the Dr. Sushila ma'am's talk, that is the management of iron deficiency anemia. Dr. Jayam Kanan, ma'am.
I am ready. I am ready. See,
Yeah.
Sushila Rani has made the journey from morbidity to the drain of resources, which is a very important factor. We may just think it is anemia, we are thinking just we are treating, but see the crores of people we have to treat. And she has said at the end that it has taken 10 years to reduce the incidence from about 57% down to 54%. For 3% a decade with so much of resources. And she started very simply with a diet. And she said, add a fish if you are a non-vegetarian and add a red potato if you are a vegetarian. Many people may ask, what is a red potato? Red potato is one thing which is available in many places, which contains the maximum iron. But even otherwise, any potato is okay, you can add every day. People think that they become obese by taking potato, but note that you are getting the good source of iron in that. And she made it very clear that if we have FCM for pregnant women, you have got Monofer for a non-pregnant female. So this is the crux of the message that she has passed on to all our delegates. Thank you very much for giving me this opportunity. Safe motherhood. Enjoy your journey and go above and above your level of the Himalayan peak which you are trying to reach.
Thank you, ma'am, for your enlightening words and your blessings too. We are really thankful, ma'am.
Can I make a point here, please?
Yes, ma'am, sure.
When I said add a fish to the pot, I was talking about an iron fish, an iron piece in the form of a fish. And, there are some people who consider even an iron piece in the form of a fish as something totally not acceptable. So I said, instead of a fish, make it a block of iron which resembles a potato. Now we are all we used to cook our food on iron utensils. We moved to steel and now we are using non-stick ware. We are nowhere near compensating our iron losses here with the help of our cooking utensils. So that is the reason I said, just take a block of iron, use it every day, whatever preparation you are making, drop that block of iron into the cooking pot and that adds a little iron into the diet. That is what I Thank you very
much. What I said has made raise eyebrows in everybody's eyes, you know.
Yes,
you don't have understood what is a fish in this
iron pot, yeah.
And a potato in iron pot. So now
we understood, yeah.
Very clearly, you know.
That's a good idea, ma'am.
That is why I pulled it out so that you are there to give the reply. Thank you.
Thank you.
Thank you, ma'am. I now request Dr. Lakshmi Shikhande, ma'am, to please give her opinion on the Professor Krishnendu Gupta's talk, that is Management of Megaloblastic Anemia, and Dr. Milind Shah's talk, Postpartum Anemia Management. Dr. Lakshmi Shikhande, ma'am.
Thank you, Bhavna. Dr. Krishnendu has given a comprehensive overview of the megaloblastic anemia, and he has rightly pointed out, if patient is not responding to your iron therapy, do think of megaloblastic anemia, and it is very easy to treat. I hope everyone remembers we used to give Itcofol injections daily, alternate day for 10 days, and our patients, they used to say that they are having a significant improvement. Provided as an obstetrician, we keep our eyes open to the entity that is megaloblastic anemia. Regarding Dr. Milind, you have given again a comprehensive overview of the postpartum anemia, the diagnosis and management. I would like to add just 2 points. The postpartum anemia per se also affects the lactation performance of the lady and can sometimes lead to lactation failure. That one point was missing from the slide. Correct. And second point is that even if the woman is having 11 gram hemoglobin at the time of delivery, and she is having average blood loss at the time of delivery, which we consider as 500 ml, even then she will automatically become anemic in the postpartum period, or her reserves will definitely be lowered. So by default, each and every postnatal woman does need iron supplementation at least for 4 months of postpartum period till her child is on exclusive breastfeeding. And how to keep her motivated and compliant towards this iron therapy, because I understand finances also becomes a problem because they would like to spend on the baby and not on the mother. Tell her that this will affect, if she doesn't take, it will affect her baby. So baby is the biggest motivation for the lactating woman to take care of herself. So we have to definitely motivate for diet, but I believe oral iron in private practice, it is really costly, the oral iron preparation, but the tablet provided by PSCs is good enough. We should tell them that it is of good quality. Please take the iron tablets provided to you by your ASHA workers or your PSC, and at least for 4 months. So this is the take-home message for postpartum anemia. And once again, I would like to thank all the 3 speakers for their expert inputs on the 3 important topics. And of course, to Dr. Preeti for having and for giving the uniform message to all our FOGSI members about 3 very important conditions: iron deficiency, megaloblastic anemia, and the postpartum anemia. Preeti, once again, 3 cheers to you and your committee. Keep up your good work.
Thank you so much, Lakshmiji. Thank you.
Thank you so much, ma'am, for your nice words and important messages which you have covered. Thank you, ma'am. And I now invite Dr. Meera Agnihotri, ma'am, our guest of honor and the expert today. Ma'am, please share your experiences about management of anemia as per your practices. Please, ma'am, welcome you.
Thank you very much. At the outset, I extend my heartfelt gratitude, first of all, to the President FOGSI and our dynamic, loving chairperson who has organized such a beautiful conclave. I believe all undergraduate, postgraduate practitioners, they will be very much benefited by it. Preeti, you deserve 3 cheers, and along with lot of love and blessings from all the persons sitting over here. Lot of us has been told about this thing. Wonderful speakers, Milind, postpartum anemia, megaloblastic anemia, Krishnendu, and iron deficiency anemia. So it was a lovely topic. They have discussed very nicely in such a short time. Only thing which I have to comment, that is from the government side, that we must know only 3 things. One, that which iron we are prescribing, why we are prescribing, how we are prescribing, what are the circumstances. Because number 1 thing which we must know that जो भारत से एनीमिया भगाओ प्रोग्राम चल रहा है कंट्री का, हमारे प्राइम मिनिस्टर का, they are targeting, and our own people must be aware what we are doing. We must know what part of the pregnancy we are dealing. Is it 4 weeks pregnancy, 8 weeks pregnancy, 20 weeks or 32 weeks? So our treatment may also be modified accordingly for the time left. We are also aware that the iron need in the first trimester, it is 0.4. It rises to 2.44 in the second trimester, 8 or maybe somewhere 10 when it is 6 weeks less than the final. So there is a rising trend. So we all know that it is the acid test of hemodynamic status. Pregnancy is an acid test. So we must be prepared. This program which is being launched, it is not only for pregnancy, it is also for the postpartum status. It very clearly says that on April 2018, it was declared that we must start iron and folic acid right from the 14 weeks onwards for 180 days antepartum and for 180 days in the postpartum period, so that it can cover all. The dose, why? But WHO is telling that you can have 60 milligram plus 400 milligram. But Government of India, we must know that we are working according to that. These are the tablets which we are distributing. So according to the Government of India, it is 100 milligram plus 500 microgram of the folic acid. According to the WHO, it is 60 elemental iron along with 400 folic acid. Why we are giving it? We must know that only 10% part of it is absorbed. So if we are giving 100, that means we are getting 10 milligram for our patient. And we must also know why we are not getting it before 14 weeks. You all know that we are afraid of something, that it may not be teratogenic, iron binding capacity may not be that high. So we are starting it from 14 weeks. So when to start and when to finish? We have to finish it in the postpartum period. Not that patient is delivered, as we have learned from the last speaker, Milinsha, that why should it be given. The details will not be covered, but these two things must be kept in our mind, that this is the daily requirement which keeps on increasing from this time up to this time, and this must be the dose. Secondly, second important thing, we must know when to give blood transfusion, exchange transfusion, intraparental therapy, intravenous therapy, or iron therapy. Only in mild and moderate, Government of India is suggesting the oral iron therapy has to be given. When should you start parental therapy? You must stop oral therapy for a certain time, then start the parental therapy. IV must be given only when we are giving blood for the blood. Patient is losing blood, iron is not going to do anything. If the patient is losing blood, she is bleeding, or this thing, this thing iron therapy will not be doing. You have to give blood for the blood. Exchange transfusion when there is an overload, that you cannot add more blood and you have to take out. So that is the time when you have to give the exchange transfusion. Hemodilution has already started by 8 weeks of the pregnancy. It continues and becomes maximum of 32 weeks of the pregnancy. So this is the time we have to add iron. Patient comes to our OPD, one line, last line. Our resident may sometimes ask, patient is very rich, madam, she can have murabba, she can have anything you suggest, any fruit, any design of the thing. But she is telling that I will not take iron. I ask them, what is your reply? If her hemoglobin is 12 gram, she is very rich, she is taking everything and she is denying to take any treatment, I will not take any tablet. Will you agree to her? No, we will not agree to her. We have to convince her that now the hemodilution is started. So each and every patient, irrespective of the creed, color and caste and status of the patient, you have to give therapy to all these patients, because hematological status has to be maintained till end. Thank you very much. You have learned a lot from others. I simply wanted to tell a few small things because the Government of India wants that these things must be propagated from grassroots to everyone. So हमारी जो policies हैं उनके according हमें क्या देना है? Why 100 milligram? Because patient will be able to have only 10% absorption. So this is the minimum which is required, and nothing more, nothing less. Thank you very much.
Thank you, ma'am. Thank you so much.
Thank you, ma'am, for highlighting the practical points, and we are really benefited by your messages and the experiences.
Thank you.
Now we move on to, before we move on to the next session to welcome our special guest, let me share an important information. That is, we have a quiz which you can, when you log in on the home page, you can see the quiz there, and you just have to click, and there are 10 questions to be attempted. Once you attempt those questions, then you can download your certificate, and I think you will really love to have that certificate, because it has 2 ICOG credit points. So do attempt the quiz and remember to download your certificate. Now I hand over the session to my respected senior, Dr. Parul Gupta ma'am, for the welcome of our special guest.
Am I
Dr. Parul ma'am?
Madam, Dr. Nandita is there to give her comments on how to improve the anemia status in our country.
I'll be there.
I request you to please be there.
I'll be there.
Madam, Dr. Nandita is coming next.
Nandita, I have to be there.
So request you.
Thank you. Thank you, Bhavna. Only one life, it shall someday be past. Only what is done for the society is what shall forever last. This stands true for none other than the magnanimous personality of our immediate past president, FOGSI, Dr. Nandita Palshetkar ma'am. Madam is a compassionate, charming lady, full of confidence, who has always stood tall towards working for women with a vision, V for Istri, during her tenure as FOGSI president. The very logo embodies the thought to empower women. Dr. Nandita is not only loving and caring for her immediate family, but also for our FOGSI family. She is also a ray of hope to thousands of childless couples, as she is the medical director of 12 Bloom IVF centers. us to her credits. To name a few: assisted laser hatching, embryoscope, egg banking, etc. She has been at the helm of various prestigious organizations like FOGSI, MOX, MSR, and ISAR, and has received various awards. Also has delivered more than 50 orations. The topic of today's conclave, anemia, is also close to her heart, and she had done tremendous work on this subject during her tenure as FOGSI president. We request her to enlighten us and guide us in our endeavor to achieve Anemia Mukt Bharat through her experiences and help us to pave our way through the trodden pathways. Over to you, madam.
Parul, thank you for that lovely introduction. I mean, it is really beautiful, and thank you very much. First of all, I want to congratulate Preeti. Preeti, तू last year क्यों नहीं मेरे साथ काम किया? Fantastic work. I mean, fabulous. And what I feel is, as I'm speaking, actually rongte aa rahe ki all the Foxians are working so hard, and I think the center of it is the woman. So I am really, really happy that Preeti has taken up this very important topic to educate our doctors, our students, and even the lay people. So I'm just going to share my screen because I really would love to talk about FOGSI's role in this anemia, what FOGSI, as a FOGSI president, what we've done before and everything. Can you see it?
Yes, ma'am.
Yeah, 1 minute. I'll just put the screen. Yeah, now I will play. Okay. All right. See, I think FOGSI, 39,000 gynecologists, and with such dynamic people. I can see, Dr. Meera, Dr. Manju, Dr. Chandravati, these senior people, Dr. Usha Sharma, they're the guiding light. And all, I can't say youngsters, but colleagues of mine, Milind is there, Lakshmi is there, Sushila Rani, what a wonderful talk it was, and Dr. Jayam Kanan, whom I really love and respect. I think that is what FOGSI is made of. And when I took over as, I think 1 minute, something is wrong. Okay, I started from the middle. Okay, so when you, Preeti took this topic, moving anemia, I think the whole country is moving towards Anemia Mukt Bharat. That is the program, and it has a lot of layers in it because of the interaction with the government. I was able to understand what they're trying to do. Remember that we feel that all the laws are only towards gynecologists. But what is important is these laws are made to protect the woman, and we have to abide by them so that the women get protected, become safe, become strong, become smarter, and a form of empowerment is given to the women. So Incurable India, we want to change it to Incredible India. And I think FOGSI has a major role to play. Everybody knows about Mohammed Fatala. I think all of us gynecologists think that the woman, when she is pregnant and when she's going to deliver, it should be the best experience of her life. And that is why it's very important to respect her, protect her, and implement the best practices. I think that is very important. And we all know there have been so many talks, why anemia is so important. 58% of the pregnant women in India are anemic, and 20 to 40% of maternal deaths in India are due to anemia. If we can tackle this, we will really be able to bring down our mortality rates, and that's so important. And mainly the iron deficiency anemia affects all life cycles, but the pregnant women and the young children, the prevalence is very, very high. And adolescent girls are particularly vulnerable. And here the question of gender discrimination, gender equality, then equity of care, which is not there in our country, and all these things the government our governments are trying to achieve. And I think that's so, so important. And remember one thing, what we are facing is an epidemic of stunted population. The next generation will be stunted. So today, the government of India has not only talked about anemia, but also nutrition, because together, this both pandemic, it's like a pandemic. Today we have the corona, but anemia and nutritional deficiency is causing a very stunted population. And as we go further into the next couple of decades, we don't want a population which is 4 feet, which are very small and lots of problems. So I think it's very, very important that each one of us takes it upon ourselves to actually bring about the change. So the adverse maternal and fetal effects are addressed. So if you see, nearly 56% of the anemia is in, the adolescent girls 15 to 19 years, 56% anemic. And these girls go on to be mothers and wives, etc. And the National Nutrition Monitoring Bureau said that actually it is the adolescent girls between 12 to 14 is 68%, whereas in 15 to 17 years, it is nearly 69%. I think this is what we have to look at, and we have to actually change, and we have to work on this. And the state-wise, I couldn't understand this. Why is there a steepest increase in Punjab, Delhi, Haryana? It's probably a nutritional deficiency, because our diets are very rich in carbohydrates, and we need to improve the nutritional content of our diets. And what is seen is poverty, malnutrition, early marriages, poor spacing between pregnancies, parasitic infections, all these cause anemic mothers and anemic infants. And I think, we are not only talking about iron deficiency. It's a holistic program that is actually needed, where we tackle malnutrition, we teach her, educate her about hygiene and nutrition. Early marriages, I'm very happy that they are actually thinking of increasing the age of marriage to 21, because it will make a difference. It will make a difference. And spacing between children, I think all this is communicating with the people. And FOGSI here plays a major role. In fact, I had the opportunity, thanks to Dr. Meera Agnihotri, I think we had Dr. Harshvardhan at the Arogya Mahila Summit. Dr. Meera Agnihotri and Dr. Rishikesh Pai helped me organize it. And you know what he said about FOGSI? कि FOGSI का काम करने का जज्बा कुछ और ही है. And that is what I'm really proud of. I mean, it's amazing what Alpesh has done this year. So many people he is mobilized, and so many people we are touching. I think it's amazing that this passion that we have, and anemia comes in that group. During my year, Preeti wanted me to elaborate what we did for anemia. I launched this V for 3 abhiyans. There were 10 abhiyans, and there were 10 FOGSI community health initiatives through which we touched nearly 5 lakh women, and 15,000 plus FOGSians participated. That is the beauty of it. I mean, where is there an organization where 2/3 of your organization has come, has participated, has listened to programs? I think it's amazing the way the passion is there in the FOGSians. And our focus program was FOGSI No Anemia campaign. So know your anemia and also say no to anemia. And this campaign was kickstarted in January with Dr. M.B. Agarwal, one of the leading hematologists, who really gave me a lot of inputs. And you can see the FOGSI office bearers as Madhuri Patel there with me, Amay Purandre is there with me, and I think that's Reena Vani who is there. ABC of CBC. And it was a wonderful program. It's been recorded and it's still available, and fantastic knowledge was parted. And these programs were conducted all over the country for gynecologists. FOGSI No Anemia camps was really wonderful. This was a very different kind of a camp. It was very innovative. We thought we'll go to the clinics of the private practitioners, and nearly 18,948 clinics were targeted. And we covered more than 2 lakh women. Each woman was tested for anemia at that point when she entered the clinics. And you can see some of these pictures. We had it all across the country. And the FOGSians and the patients really participated very, very actively. There were talks on nutrition. People were taught, a lot of show and tell kind of shows were done, and it was really fantastic. And I was really, really happy. Another program which we launched was Champions of Motherhood. Great things are done by a series of small things brought together. And I think one person who can really take this forward is Preeti. Preeti, I launched this small program, and I think you should look at it, that each gynecologist delivers at least one woman per month. We all do our work, we all do our charity work, but let us put it together and show the government what we're doing. And then these women, as women said, postpartum hemorrhage, anemia, antenatal care, taking care of them. And these are all BPL women who were taken care of. It was a very humble day. We doing it through the AMOX right now. Dr. Pardesi helped spearheading the program. Outreach programs ensuring emphasis on women well-being. So as I told you, no anemia, nearly more than 2 lakh women were touched. And SDG 2.2, what is it? By 2030, end all forms of malnutrition, including achieving by 2025 the internationally agreed targets on stunting and wasting in children under the age of 5 years, and address the nutritional needs of adolescent girls and pregnant and lactating women and older persons. So FOGSI, through its activity, is helping the country achieve its SDG. So 2.2 and 3.1 is to reduce the global maternal mortality rate. And I think that is what is FOGSI's role. Of course, the PMSMA, we have been very actively part of it, and our doctors are devoting their every month, 9th of the month, to the patients which the government has done, and more than crores of patients have been helped. High-risk patients have been identified, and FOGSI is very, very active in it. And I did a FOGSI contribution. Preeti, just 2 more minutes. Okay, I'm sorry. FOGSI has done, we did a contribution analysis, and what it talks about FOGSI. FOGSI is uniquely positioned to improve the health of women and children across the country. And as presidents, the future presidents need to consider this, because we can make an impact. We can change the life of those women. Members find the opportunities for knowledge and skill development highly valuable to improving practice and service delivery, as well as the opportunities for serving women and community through FOGSI. So, there are a lot of people who complain, too many webinars, too many seminars. I said, you don't have to attend. You listen to what you want. And eventually, this knowledge which we are percolating changes the life of the woman, and it helps in improving their treatment. The knowledge dissemination has the ability to impact health outcomes and hard to reach areas. The collective knowledge of FOGSI members allows for the development of high quality programs and initiatives that has influenced communities across the country. I think we should really be proud of FOGSI. Looking at anemia, let me look at some of the challenges and solutions, because Preeti told me, please tell me, what would you like to do? How would you like to tackle? I think we have to look at first the reasons of IDA in the Indian scenario. We do know, and we tackle them point-wise. Difference in the statewide prevalence, why is it so? I think it's all because of nutritional, because of other conditions. Short and long-term complications of IDA during adolescence and pregnancy, how compliance to iron supplements can be improved, preferred iron salts, how much difference do they make, recommended dose and duration. I think Meeraji spoke very beautifully on it. Drug, food, or drug-drug interaction. The novel iron formulations, you have so many liposomal, sustained release for better compliance and tolerability. And believe me, the government is willing to spend money. And if we find some really superb drug, they're willing to spend money on it. Efficacy and safety of IV iron in pregnancy, because the compliance is fantastic. Patient groups benefiting most from IV iron. Another thing which when I was on the platform of the Anemia, I'm still on the platform of the Anemia Mukt Bharat, and there is a publication which says that oral iron and IV iron are equally effective if your patient's compliance is good. And I think that's a beautiful statement and a beautiful study which has come forward, and it really helps a lot of patients who don't want to take IV. So what can FOGSI do to eradicate anemia? Health education and awareness in women, aggressive treatment of the adolescent anemia, universal prophylaxis with iron to all ANC patients. Through our Manyata program, we can really achieve this. And I want to really, all the champions of Manyata are here. I think Manyata should reach to each and every corner of our country, and that will really bring about a lot of change. Manyata is a FOGSI flagship program, and it'll be a wonderful thing to reach everyone. Screening for thalassemia and high-risk groups, and complete replenishment of iron stores in postpartum women. I think that's really, really important. So anemia is preventable, curable, yet a problem. Remember that it is an important contributor in maternal mortality. Mild anemia needs to be treated. Diet is not enough. Emphasize on how to take oral irons. IV iron therapy has simplified the therapy. Don't only treat the lapse, replenish the stores, and advise on discharge is very, very important. As APJ Abdul Kalam said, I would like to end my talk. A developed India by 2020 or even earlier is not a dream. It need not be a mere vision in the minds of many Indians. It's a mission we can all take up and succeed. And trust me, we are in 2020, and even with COVID, we have managed to do a lot. So thank you, Preeti. Sorry if I exceeded my time, but I could not stop myself, and I need to, first of all, thank you to the FOGSians who have participated. And Preeti, you have to take this forward, this movement which we've created. I think I can see Sadhna also there, who's another promoter of Manyata. I think it's fantastic. Manyata is something that's very close to my heart, and I feel it'll make a difference. So FOGSians work together. Leela is also there. I can see Leela now. Hi. Okay.
Thank you. Thank you so much. Thank you so much, Nandita, for your inputs. Thank you. Thank you.
One line. Preeti, can you give me one line?
Madam, we are already very late. Yes, please, ma'am. Last comment.
One important thing Nandita has forgotten, and Preeti must be remembering it very nicely. Hyderabad Palace. We have prepared for anemia. You forgot it. I should have been your secretary to add it.
Yes.
Thank you so much, madam. It was on blood transfusions and all, and I wanted to put it in and I forgot. It was.
I know. That was a wonderful meeting. We have done only anemia and anemia only.
Anemia and calcium.
I know. Preeti was telling me about it.
I reminded you, and now you add to it.
Yeah. Thank you, ma'am. Thank you for reminding it. Thank you, ma'am.
Passionate talk by the immediate past president. A true leader speaks about how the anemia can be eradicated. Thank you, Nandita, for your guidance. And it was really passionate.
Yeah.
From your heart. From your heart.
Yeah. Parulji, please move ahead with the next session.
Thank you so much, madam. Your vision and your sincerity is truly praiseworthy. Your guidance and suggestions are exemplary. We will try to follow your path and work on these points. Incurable India to incredible India through a holistic approach, thus saying no to anemia. Thank you, madam, for paving our way. Now I hand over the proceedings of the next session to Dr. Anita Tamarai Selvi.
Thank you, Parul ma'am. We have come to the end of our march against anemia through our Grand Anemia Conclave 2020. We have been listening to our experts talk about testing and treating anemia, but every time we see a case, we have doubt about diagnosis as well as treating, what to give, when to give, and how much to give. To give us a clear idea about the management of anemia in pregnancy, we have a team of experts, expert panelists with different practical solutions. Let us now go to the panel discussion on management of anemia. It gives me immense pleasure to introduce our moderator, Dr. Sadhana Gupta ma'am. Dr. Sadhana Gupta ma'am is Director, Senior Consultant, Jeevan Jyoti Hospital and Infertility and Medical Research Center, Gorakhpur. She was a FOGSI representative to SAFA, which is the South Asian Federation of OG, till August 2020. She was Vice President FOGSI in the year 2016, and she had been Chairperson Safe Motherhood Committee in the year 2011 to 14. Next, we have our moderator, Dr. Aparna Sharma. She's an additional professor in Fetal Medicine Unit, AIMS, New Delhi. She's also the North Zone Coordinator for Safe Motherhood Committee. She's also Joint Secretary, AOGD. And our expert for today who will authenticate and give the final verdict regarding the management of different scenarios is none other than Suchitra Pandit ma'am, with her 35 years of experience as a teacher and having worked in different atmospheres, including 3 years in UK. She's a senior consultant, Surya Group of Hospitals, Mumbai. She was chairperson AACC, which is an All India Coordinating Committee of RCOG in 2017 and 20. She is President ISOPAP, and she was President Justosis Organization in 2016 and 20. She has so many international and national awards in her credit. Our carefully chosen, well-experienced panel members include Dr. Leela Vyas. She's a senior consultant and aesthetic and cosmetic gynecologist in Vyas Clinic, Jaipur. She's also Vice President FOGSI in the year 2018, and she's now Chairperson ISER Chair, Rajasthan. And we have next Dr. Umma Singh, who's Professor and HOD OG, and also Dean of KG Medical University, Lucknow. She is President UP Chapter of Association of Gynec-Oncologists, and she's also Nodal Officer for Cancer Screening Program in NHM UP. We have our next panelist as Dr. Anita Sabarwal, madam. She's a practicing gynecologist in South Delhi for 30 years, and she had been coordinator and chairperson of Adolescent Health Committee of AOGD many times. We have our next panelist as Professor Nisha Singh. She is a professor and unit head of Department of OG, King George Medical University, Lucknow. And she was Joint Secretary, Asia Oceania Research Organization on Genital Infections and Neoplasia. And she's presently Secretary, Lucknow OG Society. And we have Amrita Sarkari Jaipuriyar as our next panelist. She's a senior consultant, Garg Hospital, Gorakhpur, and Ahmed Hospital, Gorakhpur. She's presently Vice President, Gorakhpur OG Society, and she was Secretary, ISOPAP Gorakhpur chapter also now. And we have as our last panelist, Dr. Anupati Rana. She's an Assistant Professor, AIMS, New Delhi. She's interested in high-risk pregnancy and fetal medicine. Over to you, Sadhana ma'am and Aparna ma'am, for the panel discussion on management of anemia. Sadhana ma'am. Aparna ma'am.
Yes, ma'am, Dr. Sadhana, are you there? Are you able to unmute yourself? Ma'am, would you like to start?
So, am I audible?
Yes, ma'am, you are audible. Is my screen visible?
Yes, the screen is visible. So, first of all, hearty congratulations, appreciations, and everything to Dr. Preeti and Safe Motherhood Committee. And again, thanks for opportunity. And I with Aparna is going to discuss few case situations, because actually with all the knowledge and information, it's what matters that what we do in our clinics, how we discriminate, how we don't miss the different types of anemia and sometimes the severe situations with the good knowledge and a good concentration and a good decision making. So we welcome all the panelists, especially we are fortunate to have the Dr. Suchitra Pandit as an expert panelist and a good experienced Dr. Leela Vyas, Dr. Uma Singh, Dr. Nisha, Anita, Amrita, and Dr. Anubhuti. So it is an amalgamation of junior and seniors, academicians, and the practitioners. So Aparna, you go forward. So we are straight away going to the case situation. Patient 21 years, primary gravida, she comes in OPD with 15 days overdue, self-pregnancy test positive, mild nausea. So she's fine, married only 1 year back. You have confirmed your ultrasound confirmation of pregnancy. Okay, so that is your choice that you do ultrasound at this level. and she was advised routine antenatal investigation. And in this investigation, her hemoglobin comes out 8.5 gram%. So Dr. Leela Vyas is with us, and Dr. Nandita has just now said that the Rajasthan has got a good incidence of anemia and the state-wise discrimination. So Dr. Leela Vyas, what do you do with this primary gravida? She is coming with 8.5. She is entering pregnancy with this hemoglobin. So
at the outset, I convey my sincere thanks to FOGSI, all Dr. Alpesh, Dr. Jaideep, and Dr. Preeti, the Safe Motherhood Committee chairperson, for organizing this CME and then panel on the practical basis, because I got her message that we should go with the practically only. And definitely it's our responsibility to convey the message to our colleagues that this is the way. And Aparna has met very nicely these questions she has put. So first thing is that you are asking that 8.5 grams, she is coming in early pregnancy just 15 days after her missed period. Yes, how to, whether we'll go to investigate or start the treatment. Again, as Nandita mentioned that Rajasthan has very high incidence of anemia. Yes, it is in both the rural as well as also in the urban area. So it all, if practically we talk about that, it all depends on the patient's history again. So if patient coming from a rural area, so one thing I'll do that definitely there is studies that we directly do the hemoglobin if you are coming in a PSC or a small center. And then, and if we have gone for that complete CBC, if in first her visit. So CBC will give so many things to clue to us that whether we go with further her means her peripheral blood film and all, then to proceed with that. In complaint, she has mentioned that mild nausea is there. So to start with the iron, yes, this in case of our patients, of a rural patients, there is one role of that giving the trial of iron therapy and see the result after 1 month that we usually do in our practice. So we will start with the iron therapy, but the issue of the compliance of that iron because of her early pregnancy symptoms. If she is having more of the this nausea and she comes the very next day that I'm not able to take and I'm vomiting, so that her nutrition will be hampered by her routine diet will be hampered. So we'll try to explain her that this is required and again see for that acceptance of that iron. So the one is the nutritional factor we will go. Yes, definitely if patient is not tolerating iron, then I'll straightforward go for the investigation and the thorough history, whether she had any history of, because the primary gravida, heavy menstrual period she had, she's a chronically anemic, or any history of worm infestation or other things. And then as in Rajasthan, I talked about that if she is coming from a good family, nutrition is proper, I'll investigate her and rule out the thalassemia also in this case, and PBF and blood test for these things. So
I think Dr. has given a very
patients and further investigation on depending on condition.
A very clear message that one thing which is actually for Anemia Mukt Bharat, we are having a lot of sessions on anemia, and still in public health facilities there is only hemoglobin in district hospital and sometimes in medical college. So I think this is one way that we should have the general blood picture in a complete blood count in our routine, so that we can detect with MCV and MCSC that it is not hemoglobinopathy and what kind of anemia. So this is one thing. And second thing, we in the first trimester, like it is an issue of nausea and the gastrointestinal disturbance more often, then we will more emphasize on the diet and the education. We take this opportunity to educate the diet, educate about the diet rich in iron. And we will just say that I will also like to have the comment of any person that as per see, we can give oral iron therapy in first trimester. We can take syrups, we can take low dose iron if the patient is having hemoglobin of that range, and let's see that what happens to the patient, because 50% of patient have nausea and 50% don't have. So we have to open our mindset that in first trimester iron is cannot be given we can use that opportunity for low dose, for syrups, or for alternative forms. I think I got your message, Dr. Leela, well, and I think Dr. Suchitra want to add, which I can see from her face.
I wanted to say a couple of things that at this outset, whether the patient is rural or whether she's from a city, very rightly, we must find out what is the cause of her low dose. Is it just an iron deficiency or is it hemoglobinopathy? So in Mumbai, at least we have a test called test for thalassemia, HB by HPLC. It costs 250 rupees. So I'm sure we can, impress upon the governments, Rajasthan, UP, or wherever. Please include this test. And as Dr. Sadhana very rightly said, apart from HB, nothing else is available. Let's push them to do this test because it saves us a lot of problems. And second thing, what I'd also like to mention here is, though we say that we should not give oral iron, I think very pertinent point you mentioned about the low dose iron is because in the period of organogenesis, you require all the minerals and particularly iron, more so when the central nervous system is being developed. So for the proper development of all the parts, small amounts of copper, small amounts of iron, small amounts of manganese is all required. So if you can give her low dose iron supplements, it would still be worth it. Of course, keeping in mind that she's got nausea. And many a times what obstetricians do is they give some kind of an antacid to the patient because she gets acidity. They talk about small frequent meals and acidity. But the problem is if you give any kind of iron and you give acids along with that, particularly the proton H inhibitors, then it will retard the iron absorption. So these are the 2 points which I just wanted to make.
Thank you very much, Dr. Suchitra, because this H2 receptor antagonist is one of the frequent co-prescription nowadays, and we have to be very sure that they don't hamper the iron absorption. So next questions to Dr. Uma Singh. Welcome, Dr. Uma Singh. When you have started low dose iron, say in the first trimester as well, and patient is able to tolerate it, then how you are going to assess that what we are giving iron, it is being effective or not? And how do you monitor that, how you decide that what should we do next depending upon the response? So what's your takeaway for this very important follow-up? Yes, Dr. Uma Singh.
So good evening, everybody. And I think for this, if we have heard what Dr. Sushila was talking and Dr. Krishnendu was saying, that, the moment you start iron to an iron deficiently anemic woman, in a couple of days, she starts feeling better. I think that is the first sign which shows that she started feeling better. You can intermittently do after say a gap of 1 week or so to look for reticulocyte count. But looking at the condition in which our women are there and the type of group we are treating, I think by the end of 3 weeks to 4 weeks, you get the hemoglobin repeated. If the rise has started and it continues, I mean, the first time she shows after 3 weeks a rise of 1 gram% hemoglobin, you know that she's on correct path. She's taking her iron well, and that's it. If you feel it is not gaining that, then is the question that you have to worry about.
One little query, I want to clarification from Dr. Uma that very early, like you say, hemoglobin estimation after 7 or 10 days. Do you recommend, and you will wait minimum 3 to 4 weeks to assess the response before switching to any alternative therapy? So your comment, and then we proceed to next question. Dr. Uma. Follow-up investigation after trial. So, should be too soon or it should be minimum 3 to 4.
It never be. It should always be after at least 1 month. Do not decide on changing drugs before you have tested for 1 month.
So that is a clear message from Dr. Uma Singh. And Dr. Nisha Singh, again, it is one armamentarium is like we say, I think panelists have Dr. Suchitra, and everything is on the low dose iron, alternative iron. Secondly, we see the response. alongside the second arm is the nutrition, because it is food what our body assimilates. So what is the role of clinician? You give prescribing and say it's on, and we have the doubts that she will not take. Already we have the doubting. What is the opportunity for gynecologists to advise her on a good iron, protein, and the rich diet which actually builds hemoglobin in the body? So as a teacher and as a practitioner, how do you advise to your women who are running pregnancy with mild to moderate anemia? Dr. Nisha.
Yeah, good evening, ma'am. Definitely, this is actually an opportunity, and this is one thing on which we have to give some time to the patient. That's very important. We have to talk to her, and we have to impress upon the role of a balanced diet, which contains the carbohydrate, protein, and also the vitamins and minerals containing things. And the meals that patient takes, she takes at least 3 major meals, and in between also, because she's pregnant, if she needs. Then whether she is non-vegetarian, vegetarian, because non-vegetarian diets have like egg yolk and liver and all, chicken, meat, fish, they are good sources. But if she's a vegetarian, then also among the cereals, the staple diet, the staple cereals that she has, they are also rich sources of iron. And the green vegetables, as we all know, the spinach, the fenugreek, and an important thing is how she cooks them. She has to wash it before and then cut it, rather than cut it and then, because it is going to you wash off all the nutrients, the iron. Then how she cooks it. Iron vessels, we all know, and then today I heard about a very nice things, putting on that iron block. So these are some of the things that we have to take some time and tell her about all these things. Then do not take it in between the meals rather than with the meals, to inhibit the absorption. Other things like tea, coffee, coke, all these things are going to inhibit the absorption, so never take it with them. Rather, ascorbic acid in the form of juices or lemon, this is going to improve the absorption. So these are the things that we have to impress upon: what to eat, how to eat, when to eat. So all these things should be included in our, I know in the government hospitals like where I work and with the residents around there, it becomes sometimes different, but we should have some social workers or some people giving some extra, or we have, on the video messages going on. So that's how we should be able to cover this up.
Thank you, Dr. Nisha. I think one message, which one suggestion and something, because as a even practitioner or even in the medical college or something, it is really difficult to advise about diet for 10 to 15 minutes. And I really think that in my 50 years of practice, the write-ups are very important. Like in antenatal card, you give the good, what Aparna has just shown, a good this to eat, because actually it's almost impossible to say about 10 to 15 minutes. So absolutely, you gave a short, crisp advice, and it should be supplemented with the write-up and the picturesque, because everybody can read it and assimilate it. It's not their family member, so it is education to whole family. So this is one thing.
Sadhana, I just wanted to add that in Maharashtra and the South, we have ragi, which we call as nachni. Ragi is an excellent source of iron as well as calcium. And now you also have quinoa, which is available at many places. So these are not expensive. These are very cheap sources. And, they can eat it. They can have the ragi with buttermilk. They can have it with, they can make it like a dalia. They can have it with a little bit of gur. They can have it with salt. Whichever form, it still gives you the iron and the calcium. And as the ragi is fresh, sprouted ragi, it is very rich in vitamin C. So the iron absorption is also much more better.
Actually, Dr. Suchitra, it is one of the things that our, like what we say, the public science, that what to eat, and an offensive advertisement of junk food industries are actually deteriorated very much our food health practices. So gourd and bajra and jowar, which makka we used to have in our childhood day, which is not being given to today's girls. So this is very important, that the local and cultural food which is available, like we give something broccoli to the woman, then most of the people don't have the taste, don't know. So the local and cultural factors, which food is available and which food is affordable, that should also be taken in account by the clinician. So So the next question is to Dr. A.S. Aparna. What does it mean, Doctor?
Anita Sabharwal.
Anita Sabharwal. So we have discussed about iron, how to don't mix the iron with the food, and about the diet. We want to have your input that in many places in even our country, the fortification of food, like iodine fortification to salt, has really made a change. And I work in the Eastern UP, and we don't see now goiters at all, which we used to see around 25 years ago. So your views and your communication that how food fortification helps in this fight against iron deficiency anemia.
Yeah.
Dr. Anita Sabharwal.
Thank you, ma'am. Thank you for asking. I'm Dr. Anita Sabharwal. So actually this food fortification has been found to be really very effective, because here the concept is to combine the commonly used food items with the addition of essential nutrient. Like you just said that iodine has been used for the last so many years. And now even iron has been added to the commonly used foods like salt and even wheat and many other things. And this has been found to be as effective as even iron folic acid supplementation. And it really helps in improving the hemoglobin concentration and decreasing the prevalence of India. And it's very cost effective, and it can be used as a long term. And we have various salts like sodium iron EDTA. And because these are very good, because they are even effective in those foods which contain phytates. So that really goes a long way. And then you can see, I was just Googling the Amazon, and we have so many fortified foods, and especially the double fortified salt that has been demonstrated to significantly increase the mean hemoglobin in pregnant women who are consuming than in those women who are not consuming. And almost 93 milligram of iron is added up in the 6 months if they take it continuously.
Oh, thank you,
So
Dr. Anita. Yes, the point is that the government of India is also with the 2018. There may be mandatory fortification of food, and the government is like working with the food industry, because that addition to cost, technology to make the content what we want to give the nutrient available, that also matters. And maybe in 3 or 4 years it may be mandatory, because again we say we can prescribe iron to those who we receive, we treat, but for the large population who is having only food, the food fortification is going to be go a long way, and
Right.
so that is very, very important. So the next question is to you, that what is the dose you give when you treat the prophylaxis of anemia patient with 11 gram, or you don't give iron if the patient is having 11 to 12 gram? And what you prefer, continuous dose, intermittent dose, or the low dose in the prophylactic treatment? And what is your threshold that this patient need iron prophylaxis and this patient doesn't need, or in our country every pregnant woman need prophylaxis? Amrita.
Yes, ma'am. Like I start iron therapy preferably in the 2nd trimester of pregnancy. And for 11 grams also, I continue giving iron prophylaxis, because with the advancing gestations, the requirement increases. The fetus is also growing very fast, and the requirement for mother increases. So we don't want her to get her hemoglobin levels low and then we start off the iron. So for this, in the program of Anemia Mukt Bharat, a dose of 60 milligrams of iron with 500 milligrams of folic acid is recommended. And then, 5 milligrams of folic acid is recommended, and WHO recommends, I prefer giving the iron and folic acid as a continuous dose. But for the intermittent part, we can give weekly dosage. And for this, the iron supplementation dose, elemental iron of 120 milligrams and folic acid 2800 micrograms can be given weekly. And for daily doses, 60 milligram of elemental iron and 400 micrograms of folic acid needs to be.
Thank you, Amrita. Actually, the basis behind prophylactic treatment is that when we get the hemoglobin below like anemic range, then actually it is the third stage of iron deficiency. First is the iron storage deficiency, then iron deficient erythropoiesis, followed by the lab values when we have got the frank anemia. So to replenish the store and to fulfill the extra demand which we are going to have in the coming pregnancy, as Dr. Amrita has said, we should give the prophylactic iron even for the women who are having hemoglobin around 11 to 12 grams. So that is the basis. And usually in our country, we want to give continuous treatment. There are many studies in adolescent or something that the continuous dose is better. But if the patient is not compliant, then we can have the monitored administration of iron. So so this question is again to Dr. Anita Sabharwal, that what is the protocol of oral iron for treatment of mild iron deficiency? I think Amrita has already taken a part of it. And if there is any addition, please, Anita.
Yes, ma'am. I think even Dr. Meera ma'am very clearly told us that as the government of India, we are giving 100 milligram of iron and 500 microgram of folic acid, 2 tablets during mild anemia. And it should be given as long as we check the hemoglobin every 4 weeks. And once the anemia is taken care of, and then she should continue with that prophylactic dose of 1 tablet, 100 milligram of iron and 500 microgram of folic acid as per Government of India. And very rightly she said, as per the WHO, it's that tablet of 60 milligram elemental iron. So this can be given even after delivery, also postpartum. It should be given prophylactically for 6 months.
So WHO for 100 days, but in our country it is for 180 days, and after postpartum it is for 6 months, and it is a very, very right step considering multi-nutrient deficiency and like full-fledged iron deficiency anemia in our obstetrical population. So
ma'am, if I add a point here, ma'am.
Yes, Aparna.
Ma'am, I would just like to say that now we have a dose of 60 milligram elemental iron, even from the Anemia Mukt Bharat. Because we have seen from various studies that beyond a limit, the iron does not get absorbed. So, the even Anemia Mukt Bharat guidelines now say that if you are giving elemental iron, because now you're giving 2 tablets of 60 milligram, which is 120 milligram. So the absorption is not increased beyond a certain dose. So Anemia Mukt Bharat guidelines say it is 60 milligram elemental iron. For
and folic acid 500 micrograms.
Yes, before treatment of mild anemia. So now we have come back, because now earlier it was 100, now it is 60 milligram elemental iron BD for treatment of mild and moderate iron deficiency anemia.
Thank you, Aparna, for this update. And so I think the question was again consider when there is another scenario is, one is the hemoglobin is on the rise and you are very happy with the iron prophylactic treatment. But now we are, after 1 month you have done your hemoglobin and it is not rising. So what's it is concern, or how you are going to tackle the situation? And it is a very, very common situation. So what are your suggestions and how do you counsel, or how do you talk or investigate the issue? This question is I think it is not a question, Aparna. It should be read out that.
Yes, ma'am. It is just a point of discussion that, at this point, probably this patient needs further investigation, that she has not responded to oral iron. So we need to consider other causes of anemia here.
So we are going to take, and this is one thing that what the WHO says and studies, that so many trial, I think Brista trial is there, that we say that in a developing countries, actually only iron deficiency is the cause of only 14 to 15%. There is multiple micronutrient deficiency, infestation, and we should take full-heartedly and all situation, whether she is taking or not iron, she is comfortable with this, and what are the alternatives. There can be alternative causes and the hidden causes which we can diagnose. So it is for this question is to Dr.
Anubhuti.
Anubhuti, yes, so she is our youngest entry in the panel, and please flash me the slide of the previous question. It is not. It is empty slide. So I think we have taken this question. Can oral iron be given in first trimester? I think we are done with this. Anubhuti, are you there? Your comment as a young OB-GYN?
Good evening to all my respected seniors. Ma'am, we have already discussed this, and the only thing is that we might not need oral iron so much in first trimester, and the absorption is also low. There's a lot of gastric irritation, but yes, if required, it can be given.
Thank you, Anubhuti, for it. And next slide, Aparna. So again to Dr. Amrita, that what is when somebody, like we are in habit of doubting our woman, and first of all we say that hemoglobin is not rising because she is not taking because of the discomfort or something. So how you give the advice that these side effects can be minimized and can be really tackled with? So what is your takeaway to all the clinicians? Amrita.
Ma'am, the patient suffers from many side effects because of the oral iron. She can have nausea, heartburn, constipation, irritable bowel, indigestion, diarrhea. And for these, first of all, we ask her to stop the treatment at first and just watch if she improves with her symptoms. And at times when she suffers from diarrhea, I tend to add the prebiotic and probiotic with iron. And I have not seen it written anywhere, but I just try and give it, and I have found some improvement in such patients. And of course, I add at times the proton pump inhibitors, which I heard is not right, but something is better than nothing. With that idea, I tend to add this PPIs, and then for few days the patient takes it. I ask her, when you have a lot of problem, you take the PPI, and if you are over with the problem, you try again and take the iron for yourself. And most of the patients start tolerating iron over a period of time. For constipation, I definitely add lactulose to the patients.
Thank you, Amrita. But a few things which we like try out, that like we are giving a higher dose, then we can reduce the dose. Again, the low dose iron, like in first trimester. Secondly, reducing the, like breaking the doses in two parts and changing it to alternative preparation, which most of the clinicians do, that it is not working. So that, but the brand which is supposed to say that it has got less gastric irritation, then we are the different choices. And fourth is, usually we don't want iron to take with meals because of phytate and hindering absorption. But if the patient is having a lot of problems GIT, then she can be advised to take with the meal, but adding of lemon or fruit juice with the meal, so that we can balance the absorption. So it is a tricky way, and to build the confidence that sometimes there is initial gastric intolerance and after that not. So
probiotics are known to help in iron absorption, but many times women tend to take a glass of milk. The mother-in-law will say, "दूध के साथ पी लो या तो छाछ के साथ पी लो." But in fact, that is wrong, because those items contain calcium, and calcium and iron should never be given together. So I think that is a mistake which many people do, is दूध के साथ ले लो. So I think that should be stopped, and PPIs definitely should not be given along with iron. If you're giving PPIs, then you have to give a good enough time interval between that.
So PPI always empty in stomach and
early morning, iron after meals.
Yes, and secondly, Dr. Sujitra has like raised another important, that we prescribe, the second important prescription is calcium. And not only milk, don't mix the iron calcium together. So calcium after food and iron a little bit between food. So no prescription to be given in which the iron and calcium are together. So this is one important. It is milk, of course, not to be taken charge, and the calcium preparation are also not to be taken with the iron. Comment from for the newer preparation, there are so many preparations which are supposed to say bypass the duodenum and they reach reticuloendothelial system, and some are enteric coated tablets. So I want a comment from the panelists. that what's your experience about one thing, entry-coated iron, which is important, say, and the newer preparation available, which are supposed to bypass the duodenum. Any comment from this? Question is not directed to anybody. So can we start with Dr. Leela Vyas for her comment? Dr. Leela Vyas.
Yes, definitely. And routine we are doing, if patient is not comfortable with the one iron, we are changing to the another iron. A newer one is the sucrosomal iron. They are saying directly that absorption is there. Yes, but it's not always with the all patients. Some are some patients still they are taking the Otrine, which we nowadays we are not writing. But they say in my first pregnancy, I took that medicine. So they all are, means it depends on person to person and the different iron preparations we are using, and it is useful for them. So if they are comfortable with these drugs, they can take. Sometimes the size of the tablet is matters. The same salt, but the size of the tablet is important. So
thank you. Yes.
We are trying to be.
But we have to see that.
Can I just say something? So basically, yeah. So if you just look at them, I would just say that if you just look at the evidence which has been there and the various reviews that have been done, so mostly we agree that the ferrous salts are better. So and most of the entry-coated tablets, or if you talk about the recent preparations, whatever they claim, most of the salts they are in the market which are available, they are not really more effective than what have the ferrous salts. So preferably we should be taking the ferrous salts then which are prescribed. So the only thing that I would like to know from Dr. Anubhuti is is there any most recent literature 2020 available from the amino acid chelates iron?
Yes, ma'am. So there has recently been a paper about an iron amino acid chelates, which have been found that they have a rapid absorption from the gastrointestinal tract, and also that there is less GI side effects. Another drug has also been come up in a big way, sucrosomial, which is also a ferric pyrophosphate. Again, it is seen to have less gastric side effects. So these are upcoming newer iron preparations.
So till we have more evidence, we can say that these are upcoming drugs. And as we know that, as gynecologists, we will probably, try them in more affording patients. But we cannot really say with evidence that the ferrous salts are what we can say right now is that the ferrous salts are better. Even among the ferrous salts, what we know till now is that the polymeric complexes amongst the ferrous salts are found to have better GI side of tolerance abilities as compared to the ferric compounds.
Yes, Aparna, initially our teachers used to tell us, if the lady is taking iron and if it's not having any side effect, that means this iron is not effective. So somehow the side effects will be there, and definitely we have to change the preparation or to the mode of taking and all that is to be done.
And Aparna, just
salt which produces some side effects.
One comment before you switch to second case situation, that Government of India has put a question bar on the entry-coated preparation, because all over the world they have not been found to be effective. So entry-coated tablets are something questionable.
Entry-coated tablet is not even logical to be used, because it will not get absorbed, because it has to have that kind of the stomach. If you cross the stomach anyway, then it doesn't get absorbed. So yes, so it is not really viable to get absorbed.
So in anemia Mukht, this is also one question mark which is like underlined beside food fortification, that entry-coated tablet to be withdrawn. Second case, Aparna, you please go ahead with the second.
Yes, ma'am. So thank you, ma'am. And so let's start with the second case. So she's a 32-year-old lady who's second gravida and para 2, rural woman who's having twin pregnancy, and unfortunately comes straight at 34 weeks, and her hemoglobin is again 8.5 grams. She had taken some oral iron which was given to her at PHCs. However, with hemogram, she also has reports which says microcytic hypochromic anemia, and which is iron deficiency. So my first question to Dr. Leela Vyas would be that in this particular case, what would be your modality of treatment and why, and what is the advantage and disadvantage of the modality of treatment that you have chosen at this stage?
Definitely 34 weeks, twin pregnancy, coming from the rural area. yes, that this will be the parenteral iron therapy, because oral iron therapy she was taking. We all know that there is no difference between that effect of iron, but she has taken that, and there may be so many factors because they're coming from the rural area. Maybe compliance may not be there, and the absorption may be poor, or some other conditions like the preparation she was not tolerating. So these are the conditions. At 34 weeks, we need, and twin pregnancy, again, the chances of having the preterm labor is again that, and we need that there should be some drug, some way of giving drug that we get effect of that, so we can correct the anemia properly in time.
Right, ma'am.
So,
very correctly mentioned.
Parental, yeah. So we'll start with the parental iron therapy.
Yes, ma'am. So very correctly mentioned, she has multiple factors. She's advanced pregnancy. She has previously taken oral. Maybe she's not compliant. So now we have nothing else. And we also want a definite replacement. So all three reasons why we want to start parenteral iron. And apart from the fact that parenteral iron results in rapid increase in HB, replenishment of stores, it has also been shown that improves vitality and social functioning. So it has multiple advantages, and we are happy to start parenteral iron. And Anemia Mukt Bharat is with us, and it says that if gestational age is more than 34 weeks, we can start parenteral iron, which is iron sucrose or FCM. So now we come to the next question, Dr. Uma. I would like to know from you, which parenteral iron would you prefer? What are the available forms? And ma'am, I would also like to know that she is pregnant. So in your practice, what form would you use today?
So as at some time we had mentioned that, earlier it started with iron dextran. And when we switched over from intramuscular to intravenous preparations, that was one big paradigm shift, because intramuscular was really bad. Now, when we started doing intravenous, then also with iron dextran, there were definitely problems of once in a while, there used to be anaphylactic reactions. And they used to be so terrible that it used to be really, really very disheartening. Life became easier since iron sucrose and ferric carboxy maltose became available. We all know both of these preparations, iron sucrose and ferric carboxy maltose, are fairly safe drugs. Iron sucrose, of course, is considered as category B drug. The iron dextran and ferric carboxy maltose, conveniently called as FCM, is category C drug. More important, apart from this, is availability. In many government setups, we still have iron sucrose available. While if FCM is available or the patient can afford, it is definitely good, for simple reason that you can give bigger amount of drug, FCM drug, in one sitting. So the woman need not come again and again. You can give as high as 1000 milligram in one sitting. While in case of the iron sucrose, you can give lesser amount. So the woman has to come again and again. The life has definitely become easier with these two drugs coming and becoming available for us.
Right. So ma'am, my question to you is that apart from the fact about availability and that it might, it might be costly, you do not have any reservations about giving it in pregnancy?
Yes, no reservations about giving them in pregnancies. Studies have shown adequate information that both of them are safe during pregnancy.
I think that's a very important message that we need to actually understand, because, as you saw that it is a category C drug, and there are still a lot of reservations of it being used in pregnancy, but most of tertiary centers are using it as FCM. And I think there is a need for generation of evidence on this for a widespread usage. So going to the next question, Dr. Nisha Singh, how would you calculate the dose? I think Ganzoni's formula is something that we can tell in our sleep also. But still, for the benefit of our audience, we should revise it that now that we are doing parenteral iron. And how is the total dose administered? Dr. Nisha? Dr. Nisha, can you connect? Dr. Nisha? Dr. Anubhuti, can you take this question in the meantime? Dr. Nisha connects.
Oh.
Yes, Dr. Nisha, can you connect? Am I audible?
Yes, ma'am.
Anubhuti, can you take this question?
Yes, ma'am. So we calculate the total iron requirement by a simple Ganzini's equation that we deduct the difference from the target to the actual hemoglobin multiplied by the pre-pregnancy weight and a factor of 2.4 and add definitely 1000 milligram for replenishment of stores. And the titration of dose is generally done on the basis of what is the ongoing blood loss, how is the available iron stores and the hemoglobin response.
The only point that we would like to add here is that, earlier we used to think it is 500 milligram for stores. And, the general amount that comes is around 1500 to 1800 milligram. And there's an interesting paper which says that if it is anything less than 1500 milligram, that really does not ensure that your stores are full. So on average, if the patient is anemic, we can be sure that you would require some 1500 milligram of IV iron to replenish the stores. So
I would just like to add another point, that the target hemoglobin which you mentioned should be 14. Very often in calculations, people take target as 12.
Yes.
That makes difference. So target should be 14.
Yes, ma'am. Nice. And can you tell us some precautions for IV sucrose? Although ma'am has told us that, we should not be too worried about, hypersensitivity reactions. But, there is the prerequisite that we should be careful. So how should we go about administrating iron sucrose?
So we have, a 5 milliliter vial are available and it is 20 milligram elemental iron per ml. So you make the solution that 200 milligram per dose in 100 ml of normal saline. You start the infusion in the initial stages slow. That is something like the testing.
Yes.
So during the first 5 minutes, give infusion slowly at the rate of 20 to 30 drops only per minute. And in that 5 minutes, somebody should be closely observing the woman. Once that 5 minutes has passed without any apparent reaction, that is, the woman suddenly does not start feeling breathless, there's no tachycardia, there is no fall in blood pressure, there is no erythema, or those shivering, etc. are not there, then the infusion rate can be increased and rest of it can be given at the rate of 80 to 90 ml per minute rate.
Yes. So
thank you, Dr. Uma. But I really want to highlight that Madam says that there should be one person, but there should be always readiness to treat anaphylaxis.
Oh yes. Oh yes.
We have like report from every drug. It is the iron and understanding. So we
thank you for that
very, very hurriedly. So
yes.
the next question.
Thank you for that point, because that is exactly my next question.
Yes.
Yes. So, Dr. Anita, what are the side effects and precautions to be taken? Because whatever you say that there is no hypersensitivity, there is nothing, in effect, we are giving an IV injection. So we should have an emergency tray. So we should be giving it in a place where there is an emergency tray. So we have to be prepared. So ma'am, what are the side effects and precautions to be taken while administering parenteral iron? Just before this point, by this slide, what we wanted to emphasize is that iron sucrose minimum gap should be 3 days, and for FCM minimum gap should be 1 week. So this is something that we need to, remember that while we are calling the patient again. So Dr. Anita, are you there? Yes.
Yes, Dr. Aparna, I'm there.
Yes, ma'am.
Yes. So as we've been talking only that all IV formulations, they may have allergic anaphylactic reactions even now, so which are in the form of nausea, hypotension, tachycardia, chest pain, breathlessness or edema. And so we should be ready for that. We should know how to manage that. And there could be some minor infusion which is self-limited and it rarely recurs, and there is self-limited arthralgia or myalgia. And the precautions, that is why we should always first confirm that this is, the diagnosis should be confirmed that this is iron deficiency anemia. And the patient should have stopped oral iron at least 24 hours prior to this therapy. And it should be at a place where we can have a proper supervision and we are able to manage the anaphylaxis. So these precautions must be taken.
Thank you, ma'am. Although the hypersensitivity is next to nil, we should still be careful and follow all precautions. And as mentioned, the test dose in the form of initial slow dose should be given. So
Aparna, can I just mention one thing? Before giving the iron, I think there are 2-3 pertinent questions which you have to ask the patient.
Yes,
history of allergies, history of previous anaphylaxis. There are times when patients don't tell us, and then we are caught by surprise. So that question must come in before giving any iron IV, any IV preparation per se.
So that's a prerequisite.
So we don't give it in first trimester, and also if a patient is having acute infection or some liver disease, then also we prefer not to give.
Certain prerequisites and contraindications actually in the first slide that we it is very important that we know the contraindications to IV iron preparation is an anaphylaxis, sensitivity, first trimester of pregnancy, liver disorders. All of these are contraindications to IV iron therapy. So thank you for bringing that point out, ma'am, very well. So now that we have given total dose iron, now this is a bit controversial. So should we continue oral iron or we should not continue oral iron? So that is my next question to Dr. Amrita.
Yes, ma'am. If oral iron was being given, then oral iron should continue for at least 3 to 6 months, till 3 to 6 months postpartum. And for IV iron, we do not need to repeat the dose of IV iron, but we can still continue with oral iron after a week or so.
And what do you feel, ma'am, Dr. Suchitra?
So after parenteral iron, you have to give time for that iron to act. And at least for a minimum period of 3 weeks, you should withhold giving any oral iron therapy. Oral iron continuing till postpartum is fine. But with parenteral iron, please wait for at least 3 to 4 weeks before you start off the oral iron again, because the receptors are completely blocked. But so if you give additional oral iron, it will be like an overload, and there will be unnecessarily free ions of release, which are not going to be helpful.
Yes, ma'am.
Ma'am, receptors will be blocked for 3 weeks, ma'am. That's a question.
No, Dr. Amrita, and that is another point, because that is first of all why the routine oral iron supplementation is not being done in developed countries. That is number one. The IV iron that you give is actually fulfilling your iron stores also, while oral iron that you give is not actually filling your iron stores. So that needs to be continued. But the IV iron that you're giving is replenishing your iron store. So any amount that you're giving over that can cause oxidative damage, as mentioned by ma'am. So there is a bit of controversy around giving oral iron after IV iron. So we should withhold for some time, get a hemoglobin done. So we should not run to replace oral iron after IV iron, but oral iron after correction of anemia by oral iron should be continued. So I hope the message is clear that, after IV iron, do not run to oral iron again.
Aparna, one thing I want to mention.
Yes, ma'am.
We have seen practically, even in the medical college, the patients are not coming afterwards. That sucrose, iron sucrose, usually as Dr. Uma has clear-cut mentioned that in the government hospitals, only the iron sucrose is available. So they are not coming. After 2 injections, they say, we are not able to come, just to write us. That time it is required that we have to prescribe the iron and take that. So
yes,
even in the parenteral, the compliance is very important.
Ma'am, that is very important, because it is written that once you achieve the required hemoglobin level, then only you should not give oral. If you have not achieved the hemoglobin level and you are not able to continue parenteral, you need to give oral iron.
Yes.
So that anyways needs to be given.
Yes.
So that is yes. So Anubhuti, I would like to know from you, now we have this big armamentarium of IV iron, and we have a woman who's not just a pregnant patient, but she's also a gynae patient. So what are the other indications for administering parenteral iron? So just one weapon that we can use in other indication as well.
It can be used in the postpartum period. It can be used even for building up our gynae patients in the preoperative period. It is used in all conditions in which there are gastrointestinal malabsorption syndromes, because parenteral iron will directly get absorbed from the reticular endothelial cells, and especially in conditions with iron deficiency where the stores cannot be released for erythropoiesis, like inflammatory bowel disease or cancer. So these are certain conditions where parenteral iron will be very helpful.
Right. So
I would just like to add here, because this is a very important point. I think there must be a policy in every setup that any postpartum woman who had come as anemic woman being discharged from hospital Please do not rely on her compliance of oral iron therapy. Had she been compliant, she wouldn't have ended up as anemia. We must push the iron into their body in postpartum period and then only discharge them. Forget about, other things and idealistic things that give them oral and they will eat oral.
Yes,
secondly, only thing I would just like to add, some patients of gynecological conditions like prolapse, etc., please do not preoperatively make them fit for surgery by giving them, blood transfusions. Give them iron, take some time, and avoid the unnecessary blood transfusions to them.
Here, one thing I will like to add, Aparna, for this issue preoperative gynecological condition, we have to make the difference that we give the FCM for preoperative build-up. It is not that today you give FCM and tomorrow you are going to take surgery like submucous. So it takes 3 to 4 days to improve oxygen carrying capacity. And that's why it is in post-operative, it is not only pre-operative, it is post-operative condition when FCM things can be very, very effective. So a little difference, a little intricacy.
Right,
So,
ma'am. So I think two very beautiful points have been brought out by Dr. Uma, that postpartum iron can be a very, very powerful weapon to treat anemia in the women and prepare them for future pregnancies. And preoperative gynae is one major indication where IV iron can play a big role. So thank you, ma'am. And now I would just like to introduce...
Aparna, one point if I can make.
Yes, ma'am.
Along with this, even antepartum patients where you're anticipating a big blood loss, like antepartum hemorrhage, low-lying placentas, even those patients, it's worth giving injectable iron so that at least their iron stores are better. Whatever oral iron you're giving, it may not build up that hemoglobin. They will need blood eventually at the time of delivery, whether Caesar or whichever way you plan. But if you give them the injectable iron, you're sure that at least they will withstand that particular surgery. You may still need blood, but this particular point helps us to reduce the amount of blood that we require.
Yes, ma'am. Yes, ma'am. So thank you, ma'am. So I'll just ask Dr. Sonam, are you here? Sonam is my postgraduate. She has really worked hard with me on all of these modules for anemia. Sonam, are you here? Sonam?
Ma'am.
Sonam, I just want you to tell us, in your practice, in your daily practice, what are you seeing for management of antenatal anemia in pregnancy? What are you using in your routine wards?
All antenatal patients, we are advising hemoglobin at their first visit only, and looking for
which form of IV iron are you giving?
Ferric carboxymaltose we are giving.
Right. So thank you, Sonam. So I think this is the practice, and this is our paper from AIMS where we have used FCM in antenatal pregnant women, insisting that this is safe. We found it safe, and this has really changed our practice. So with that, we come to the end of our second case, and I think we are really running late. So Dr. Sadhna, can you just take the third case? And after this, I think we'll have to quickly finish it.
Yes, we will. So it is a case 25 years old, Revda 3, Para 2, Labor 1. She is 24-week pregnancy, hemoglobin 8.5, and she is fortunate that you have done her CBC, and the result is with you. With the result, hemoglobin is 8.5, MCV 87, MCH 24.7, MCSC 28.4. Peripheral blood. So this is the picture, and these are the iron values. She has been, I think, in AIMS, so she has got all the values: iron, ferritin, PIVC, serum B12, and folic acid. So you see, MCV was 87. Like we will say that it is beyond the limit of the thalassemia, but the B12 and the serum folate level were reduced. So these are the picture. Next slide, please. So what is your diagnosis and how would you start the treatment? Again, Dr. Leela Vyas. So difficult situation to Dr. Leela Vyas. Dr. Leela Vyas.
Yes. The values are indicating that it's not iron deficiency anemia. It is associated with the folic acid and B12 deficiency. So these patients are not will not respond to only to the iron. Then we have to add the folic acid supplementation and B12. and I think Dr. Krishnendu has covered everything in a very detailed way, that how to go with that. Still we have that whether we go with the injectable B12 or we go with the oral. And yes, in our antenatal patients, we want means permanent, and this we should be assured that the patient has taken. That's why we are going with the parenteral B12 correction. That is the 1000 microgram parenterally once per week until the deficiency is corrected, then once per month, which schedule has been taken. And yes, definitely, if the patient is not able to take, or she is not coming routinely or coming for that parenteral, yes, oral we are supplementing, and oral is also having that response with this. And simultaneously, the folic acid deficiency we have to correct. So folic acid to be given, that therapeutic dose we usually give the 5 milligram per day till the 4 weeks, and these patients are to be given. And so definitely the one important thing is that if you have seen the lady is having this anemia, you go with simple this CBC and PBF. These two, and that should be every our resident should learn, and all our young practitioners should have habit to read these CBC report and the PBF report, and then further you go with the iron estimation and ferritin, which has the role, because we are not going on detail that how to. I think the next question will be there. So which is to be taken under consideration. So these, we routinely what we see in our OPDs and all, ma'am, the resident used to say that, ma'am, we have sent for the iron study total. So have you seen that report? Have you seen that CBC, that MP, you have given that attention towards that? As Dr. Suchitra has clear-cut mentioned that HPLC. Yes, Suchitra, there is the information for you. Even in the government, the HPLC can be done, whether you prescribe it, the free can be done in the government setup. But yes, in the private setup, it's not very costly, as you are doing in 250, but here in Rajasthan, all labs are doing in the 1,000 rupees. So if 1,000 rupees is invested in a proper direction, definitely we can pick so many cases of the thalassemia and all. Sorry, Aparna, I have diverted from that point.
Thank you, Leela. It was very good, actually, because in routine
this has been covered by Krishnendu completely. So I'm not going into
so great.
The
One thing
points which we miss is like we are not giving our attention towards the CBC to reading that. And I don't prefer, even in the medical college, I never preferred that you send to the hematologist. Why the hematologist? This is our domain, and we have to see, because the lady will not go. You will lose your patient if you are sending to the hematologist. If any pregnant lady going to a hematologist OPD, they will not take care of it. They will say that, hogi, the junior resident will see. Where here the professor is, why we shift them there. Yes, if you are not able to treat any other thing you are that finding, then you treat for the special treatment.
Thank you, Leela. That was wonderful. Actually, it is a real situation. It is very easy to say multidisciplinary unit, but it is very difficult for a patient to give 2 or 3 days to be in queue in multiple specialty. So we have to have the reading on CBC very carefully. We have to be very careful what is the multiple micronutrient deficiency. Again, I say the hidden hunger is supposed to be like a multiple micronutrient deficiency for the cause of our failure in war with anemia, and we have to be careful about it. And again, there are few situations, and nowadays very common with IVF pregnancy and with patient on neuro and drugs on that, we should be take good history that who are the patient who are prone to develop the megaloblastic anemia. So I will say this question is to Aparna, to which panelist. So please you guide so that just enumerate which are the condition we have to elicit in the history that these patients can be more prone to megaloblastic anemia. Aparna, you direct the question.
Unmute yourself.
Yeah. So, ma'am, basically because of the shortage of time, we have just kind of closed this. So, ma'am, Dr. Suchitra, can you just comment on this part so that we can just kind of sum up this case that, most of the things have been covered anyway in megaloblastic, the dose of B12, the dose of folate, but we have to really identify the women who would be at the risk of megaloblastic anemia.
I think basically the dimorphic picture, if you've seen at the first visit, along with the hemoglobin, if you've seen the peripheral smear, We'll also see the type of the pattern will be, it gives us some idea about whether it's a macrocytosis, whether it is prone to megaloblastosis. But when women are basically with epilepsy, they're taking anti-epileptic drugs, there's a very strong risk factor, or women who had some kind of a prior, therapy where they have probably had, malabsorption, or they've had difficulties in absorption. So they would probably give you that history. Again, women who are having excessive vomiting in the first trimester, they are prone again to, the folic acid as well as the vitamin B12 deficiency. But in our country, particularly where they are having a pure vegetarian diet, and even I've seen the hardcore non-veg eaters, some of the Muslim patients, they completely go off a non-veg diet and they stick to vegetarian. Again, they tend to have this kind of a vitamin B12 deficiency. Another common point which we have seen is women who are living in the, say they are susceptible to, they've had a sickle or they've had, malaria in the past. Again, in these patients, there's a chance of having a folic acid as well as a vitamin B12 deficiency. And of course, malabsorption syndrome, it is common, but not the full-blown picture. But you have patients who have a kind of an irritable bowel syndrome where they are not able to absorb not just the iron, but even the folic acid as well as the vitamins. So again, those kind of women, they will have this problem. And patients who are, who are prone to having, probably they've had a worm infestation. Again, in those cases, sometimes you may have deficiency of the vitamin B12 also. It's not very common, but women who've had a bariatric surgery and then they go in for a pregnancy, these women tend to have a lot of vitamin deficiencies, folic acids, vitamin B12, and so they have to be prescribed special supplements. Of course, that is not a very major chunk of our practice, but I think these are the common conditions that we look for. And another thing is the GERD. The GERD also prevents patients from taking stuff, and they tend to have kind of a gastritis. So they also can have, the picture of vitamin B12 deficiency as well as a folic acid deficiency.
I would just like to emphasize, out of all the conditions nowadays, what is the biggest cause is the junk food.
Right, ma'am. So,
Yes, ma'am.
I think that's a very important cause that you have said, you have mentioned, and then obviously the lack of balanced diet and how we have actually messed up our diets. So I think, Dr. Sadhna, we are running short of time. So I think we have covered the major form of anemias. What is left is thalassemia and sickle cell. I think we can skip it. And I think we should just close this panel right now.
Yeah,
So
only few messages about thalassemia must be given. That the moment, at least, if there is in bigger institution, universal testing plan, well and good. But if it is not there, then any woman who is constantly remaining in low to moderate hemoglobin level, in spite of treatment, we must always test for thalassemia.
Right, ma'am. Yeah, I think that's very good. And here, if you look, this hemoglobin was 7 gram% and her RBC count was 4.1. So this is a simple index, which is a Menzel's index. This is our own patient in the ward right now who was admitted. And the only reason for doing HPLC was this, and it turned out to be she's thal minor. So if the MCV was 58, so MC 58 divided by 4.18, if it is actually, it was 13. So this was a very simple indicator which you can do from any CBC. So this is a simple indicator, screening test for thalassemia. That's another indicator. So, and we should always look for thalassemia. So that is an important.
Aparna, today, because of mixed marriages, previously we used to only think it's in the Rajasthan community or the Punjab community, but now because of mixed marriages, I've had a Keralite patient who is a thalassemia minor. So if we don't do this test in time, if we know that she's thal minor, apart from anemia, we also have chance for a prenatal diagnosis. The husband can be tested also. So we prevent one big problem. Otherwise, you'll have, thalassemia major baby being born. So that is something, it's a very important aspect of this.
Yes, ma'am. We had all those questions lined up, but I think,
so short paucity of time.
Wind up right now. So I would really thank all the panelists and Dr. Sadhna Gupta for this enlightened discussion. And Dr. Sadhna Gupta, ma'am, your comments, ma'am, please.
So actually, we are FOGSI with all the committees and with what is our contribution to safe, like Anemia Mukt Bharat. I think such academic sessions, and we have to like change our attitude and the vision for it, that we can make it, and the right diagnosis, right prescription, right follow up, and a good public health policies like fortification. It is all sum up, and we have to be again aware, because I have done a rigorous study in some upcoming FOGSI conclave on the anemia, and it is an eye opener that the developing countries has much more hidden cause for the iron deficiency anemia, and we have to treat malaria, chronic parasitemia, chronic born infestation is there, and the infection, chronic inflammatory condition. My one last comment is also that we know we don't want to read iron metabolism, and still we are having new and new upcoming theories about iron metabolism. So science is always there. We enrich, we like fulfill our science with our experience. And as a clinician, we should like notify, we should document our experience. It is not only aims, which should do, every clinician should document their experience, their problems. We should not be hesitant. We should be vocal about our experience, and we should talk for our people. Thank you again. Once again, it was wonderful to be with Aparna always. And it is, she has been our always integral part of our so many programs. Thank you once again to all panelists, wonderful panel, Dr. Suchitra, Dr. Leela Vyas, Dr. Umar Singh, Nisha, and everybody. Thank you. So that we can sum up, Aparna. For
Thank you, ma'am. A great panel, ma'am. And Madam Suchitra's inputs were too good. Thank you.
I'd like to thank Preeti for coming up with this brilliant idea. And I'd like to say that, these slides should be shared with a lot of people. Small little things with the practice, practical points, where Uma has suggested, Aparna has suggested, Dr. Leela has suggested, so many practical points come up together, and we realize, what we were doing earlier perhaps had to be a little modified. I'd like to just impress upon one point. That the junk food bit of it should be taken care of by the parents, but let's start improving their hemoglobin light at the adolescent level, so that when they reach that marriageable age, they're already having a good hemoglobin and a good reserve of iron. So I think that is somewhere where we can start, and we can say, okay, fine. And I'd also like to tell you that in the geriatric age group, the incidence of anemia is extremely high. So we are a young nation now. 20 years down the line, we'll be an older nation. So our older people also need to be protected. So in any case, hemoglobin and protection of anemia is very, very important.
Thank you, ma'am. Thank you.
Anita? Dr. Suchitra, I just wanted to make a comment that we have decided to come out with a module after these two sessions, and I'm really thankful to Lupin because I told them we will be having some suggestions and input during the Grand Conclave. So we will incorporate all those things in this module, and then we will distribute to all the FOGSians. So this is our next plan. After the Grand Conclave is over, we will definitely go ahead and again modify these modules once again. And we have already done a survey on anemia with our OBGYNs, and definitely we will take up again next year to hit again the management of anemia, because there are still a lot of practice gaps that are prevailing in our OBGYNs. So thank you so much, all the faculties. Thank you, Suchitra ji. Thank you, Sadhana ji. I think Anita, you can conclude.
Yeah. One minute.
Yes, ma'am.
I'll just say something. Okay.
Yeah.
Ma'am, please go ahead, then I'll say.
No, I was just telling Anita to wind up the panel.
Ma'am, in spite of the shortage of time.
Okay. I was saying, in Delhi, I am so impressed today, and such a great learning experience. And I think we should have a lot of awareness campaigns also for the general public also. So in Delhi, we have Dr. Aparna. So we are really going to have a lot of such sessions. So please do all of cooperate and give us your support. So we'll do it.
Sure, Dr. Anita.
Yeah.
Yes, ma'am.
Anita,
In
please.
spite of the shortage of time, it was a power-packed session with so many take-home messages. In fact, as Madam said, everybody got many screenshots which has to be preserved and in our OPDs and wards. Our sincere thanks to our panel. Now we hand over the session to Bhavana ma'am for question and answer part. Bhavana ma'am.
Yeah. Hello. Yeah, it was really a wonderful session, and I think many questions in the chat box have already been covered with the discussion, although we had really had so many questions. So I'll be taking just one or two important, I think, which needs a bit more elaboration. So first question is, newer documentation favors low dose oral elemental iron, and patients have achieved higher adherence with the low dose. So iron amino acid chelate 30 milligram helps in hemoglobin rise and with least side effects. What is your take on this? I think Dr. Suchitra ma'am, I would like if you can please elaborate on it.
Unmute. Suchitra, unmute.
Today, there is a consensus for moving towards the low dose iron therapy. Either it could be a daily low dose or it could be an alternate day same dose therapy, simply because you don't want to burden the patient. And there's a wonderful paper on the iron chelate. They've compared ferrous fumarate with the iron chelates, and they found that the patients who were taking the amino acid chelation, probably in those cases, because the absorption was better, the gastric side effects were lesser, the compliance was much better, the hemoglobin and the ferritin levels were significantly better. So yes, when you have these newer iron molecules, certainly they play a big role in preventing the patients from getting disillusioned with the iron therapy. So yes, there's a great big role of this low dose therapy, definitely.
Yeah, ma'am. Thank you, ma'am. Thank you, ma'am. And a bit about what is Saurashtra hemoglobin and its implications. Any faculty who would like to take Saurashtra hemoglobin and its implications? I think it's Dr. Lakshmi Shikhande, ma'am, if she is here. In her area, it's more prevalent.
Really don't know about this Saurashtra hemoglobin.
Saurashtra should be from Gujarat.
Yeah.
If it is a variant of hemoglobin, it needs to be existing with some other form of hemoglobin, and then it needs to be seen whether any testing needs to be done. So there is actually a matrix in which we have to see the combination of hemoglobin between husband and wife. So in one particular set, the prenatal diagnosis needs to be done, and in which it needs to be done. So maybe we can review and get back.
Because in our side, Vidarbha, the sickling is very common. Sickle cell anemia is very common.
Ma'am, please unmute yourself.
I'm unmuted. So
sickling.
I said
Dr. Bhavna, we do
homework for
sickling in our
faculty.
area.
Homework for faculties. Homework for faculties.
Okay, and so one of our participants wants to know about the sucrafil iron. Any comments on that? Is it new molecule sucrafil iron?
The sucrafil iron is basically a sucrasomial technology where there is an iron pyrophosphate and that is surrounded by a lipid layer. It's a bilipid layer which is made of, which comes from sunflower, and then it has a sucrester covering. Sucrester is sucrose and ester, which is made from saponification of fatty acids. So the advantage of this is it does not have to wait to get broken down from ferric to ferrous. It can directly be absorbed as a vesicle through the para cells, when it's going inside the gastrointestinal tract. So directly the M cells in the lamina propria, they can directly absorb it. So the absorption rate is almost 80 to 90%. So the side effects, gastric side effects are much more lesser. So this again is a newer technology, sucrosomial iron, where there are a lot of formulations available in that. It is slightly more expensive than the general iron preparations.
Thank you so much.
Yeah, it's almost
chronic gastritis.
It's almost with the chelated iron, and this rate is hardly 2 or 3 rupees less only.
Yes.
Actually,
Thank
I
you
think
so
for the final thing, we have to wait for another 6 months to 1 year so that our clinician experience will be accumulated. But this is supposed to be good technology, and there is, of course, improvement in the acceptance. In a very resistant cases, I have used and they are able to take. So let's try the many thing, and we will have the experience like
Even in the chronic inflammation.
So
Even in the chronic inflammatory conditions.
yes.
So
The hepcidin barrier has been like bypassed. So when the PC will do the second conclave next year, they are with years. So we will be like dashing our experience.
Thank you so much. And I think before Vinita extends her vote of thanks, it's my moral duty to thank Aparna, Anubhuti and team, All India Institute of Medical Sciences, New Delhi, for framing all the modules for both the days, or the diagnosis and the management part. And we are really very thankful to you, Aparna and Anubhuti and all the people. And Somna, thank you so much. And we will definitely stick to these modules in our next session also. So thank you so much. Vinita, now you can proceed with the vote.
And you can say, Preeti, such a dedication. Aparna's son has got accident last day, and we were talking light at 12 midnight about this panel, that how we will go ahead. So that is the dedication of FOGSI and Aparna and everybody, that despite all odds, she is there with all energy and enthusiasm.
How is he?
So,
definitely. Kaise Aparna?
Okay. Okay now.
तो थैंक यू मैम, और डॉक्टर अपर्णा के लिए एक बार फिर तहे दिल से शुक्रिया सभी की तरफ से, सेफ मदरहुड कमेटी और फॉक्सियल्स की तरफ से, कि इतनी सारी प्रॉब्लम्स के बीच में भी उन्होंने इतना सुंदर मॉड्यूल बनाया हम सब के लिए. सो बी थैंकफुल फॉर व्हाट यू हैव and you will end up having more. So we have chosen to a musical way to thank our faculties. Let me thank first of all,
Preeti.
Start by giving glory to the Almighty God for making today's occasion a resounding success. I consider it a great privilege to propose a vote of thanks to all the dignitaries who have witnessed it a memorable and a successful Grand Anemia Conclave. On behalf of Safe Motherhood Committee, I extend my gratitude to FOGSI President Dr. Alpesh Gandhi sir for his words of encouragement and continued support for all the activity of Safe Motherhood Committee. We are grateful to Honorable Deputy Chief Minister of Uttar Pradesh, Manani Shri Keshav Prasad Maurya ji, who despite of his busy schedule has found time to grace the occasion as chief guest. I may like to express our sincere thanks to Dr. Atul Ganatra, Vice President FOGSI, for his able guidance. I wish to express my gratitude to Dr. Jaideep Tank, Secretary General FOGSI, for his continued support in all endeavors of Safe Motherhood Committee. I may like to express our sincere thanks to Dr. Chandravati Madam, as she is the National Coordinator of the Safe Motherhood Committee, for her ever-ending her blessings. I would like to place on record my deep appreciation for ICOG Chairman Dr. Mandakini Ma'am, Meg Ma'am, and ICOG Secretary Dr. Parag Biniwale sir for granting ICOG points for this grand conclave. I wish to express my sincere thanks to Dr. Nandita Palchitkar Madam for gracing the occasion. We also would like to acknowledge our gratitude to Dr. Veera Gnotri ma'am and Dr. Suchitra Pandit madam joining this conclave and giving their expert comments. We are grateful to our esteemed chairperson, Dr. Jayam Kannan madam, Dr. Manju Shukla madam, and Dr. Lakshmi Shrikande madam for gracing the occasion and adding their valuable inputs. I must mention our deep sense of appreciation for our learned speakers, Dr. Sushila Rani madam, Dr. Krishnendu Gupta sir, and Dr. Milind Shah sir for excellent explanation of the topics allotted to them. Myself highly thankful to Dr. Sadhna Gupta madam and Dr. Aparna Sharma for moderating the excellent panel with extraordinary panelists Dr. Leela Vyas madam, Dr. Uma Singh ma'am, Dr. Anita Sabharwal ma'am, Dr. Nisha Singh, Dr. Amrita Japuriyar, and Dr. Anubhuti Rana from AIIMS. An event like this will not happen overnight. The wheels start rolling weeks ago. It requires planning and a bird eye for all details. We have been fortunate to have a leader like Dr. Preeti Kumar ma'am and very motivated and dedicated Safe Motherhood Committee team. I thank each and everyone for extending their willingness, the task allotted to them, and performing their task with very loving attitude. So, for making this event a successful, I thanks to my co-convener, Dr. Meera Laktakia, Dr. Rajul Singh, Dr. Sangeeta Mehrotra, Dr. Vidya Chaudhary, Dr. Bhavna Khera, Dr. Parul Gupta, and Dr. Anita Thamarai Selvi, and Dr. Amrita Agrari. I also would like to acknowledge the efforts of Lupin, our academic partner. And once again, I also want to highly indebted to the working day and night Dr. Aparna Sharma for taking so much pains to formulate all the module of Grand Anemia Conclave, and these modules are the milestone in the management of anemia. एक बार फिर डॉक्टर अपर्णा आपको बहुत हार्दिक बधाई और बहुत शुक्रिया हम सब की तरफ से. And finally, we are in the last phase of thank you. We also we thankful from bottom of heart to the wonderful audience who turned up in such a great number, around 1700 plus, for this Grand Anemia Conclave. So एक बार फिर सभी का धन्यवाद, शुक्रिया, थैंक यू, और जुड़े रहिए आगे ऐसे ही कार्यक्रम के लिए. Over to Dr. Preeti ma'am.
Special thanks to all my seniors who are still logged in, Dr. Krishnendu sir, Dr. Uma ma'am. Thank you so much for sparing so much time. Dr. Meera Gnotri ma'am. I can see Dr. Lakshmi Shikhande ji. Thank you so much. Dr. Manju Shukla ma'am, always so inspiring and helping. Thank you ma'am for being here. Now I request all the seniors and faculties who are logged in till now, I will need your help in framing the modules. Kindly, I'll request you all to extend your support so that we can make a wonderful module after this Grand Anemia Conclave, and we can distribute to all the members of FOGSI. So thank you so much, and we will again meet soon with a very grand program on anemia once again in 2020-21. Thank you so much.
For logging out,
Congratulations.
And heartiest congratulations.
Thank you very much for
to Dr. Preeti Kumar for doing such a wonderful anemia conclave and bringing anemia to highlight. I mean, for media attention, for members' attention, for the office bearers' attention. So again, kudos to you, hats off to you, Preeti, and keep continuing your good work towards the safe health of our mothers.
Thank you so much.
I stayed till long to just acknowledge your efforts and your vision and mission for the safety of our women.
Thank you so much. Thank you. Thank you.
Congratulations, Preeti. बहुत congratulations.
Lupin team, do you want to say something?
Madam, first of all, good evening to everyone who all are connected. Our sincere gratitude, ma'am, to Alpesh Gandhi sir, who is the president FOGSI, along with the whole committee of FOGSI, ma'am. And then to you, ma'am, you are chairperson of Safe Motherhood Committee and the whole team of Safe Motherhood Committee. Ma'am, last, I must say 1.5 months have gone in and building all these modules. And it was not easy, but I believe, ma'am, such kind of partnerships are the road ahead. We together, ma'am, as a pharma company, ma'am, we promise you that we'll stand this purpose so that things we can move the cusp somewhere so that anemia can be taken care as what the FOGSI's mission is, as what the Safe Motherhood Committee's mission is, ma'am.
Thank you so much, Abhishek. Now we say final.
Yes.
Bye.
Bye.
Thank you. Bye. Thank you so much. Thank you, Furkan. Thank you for all your help and support. Thank you, Team Safe Motherhood Committee. Hip hip.
Hooray.
Hooray. Hip hip. Hooray. Hip hip. Hooray.
They do so much personal
Thank you, ma'am.
follow-up. I
Thank
really
you.
appreciate for all the activities. So much personal attention to minute details. I mean, really hippie hooray to the Safe Motherhood Committee.
Thank you so much.
Thank you,
Thank you.
Ma'am, all credit goes to our leader, Dr. Preeti ma'am.
अरे वो तो है रे, पर लीडर के सोल्जर भी तो होना ना अच्छे, सोल्जर्स भी तो अच्छे हैं.
मैम लीडर का डेडिकेशन देख के अपने आप मोटिवेशन हो जाता है.
I mean, your leader is very blessed to have such a committed and devoted soldiers. Preeti, am I right?
True. Yes, true.
Committed and devoted soldiers है, तो it is
Yes,
mutual,
true.
you know, mutual है.
Mutual है, बिल्कुल mutual.
Yes, ma'am.
Thank you so much. Bye bye. Bye bye.
Namaskar, ma'am.
Thank you, sir.
Madam,
Thank you.
close now.
Yeah, close.
Yeah, close.